Okay, beta. Now I hope so that everything is clear now. Now it's not lagging. I think it's better. Okay, so let's start. Let's start. That we were talking about. The next topic is urine osmolarity. What is the meaning of urine osmolarity? But if you remember the first class, I told you what's the meaning of osmolarity. Osmolarity means that osmolarity means that how much solid particles present into that solvent. That is the osmolarity, right? And what is the normal osmolarity of the plasma? So normal osmolarity of the plasma is roughly 300 millimole per liter. It is 285 to 295, right? Now, what happens whenever the blood is coming into this area? Whenever the blood is coming into this area, this is filtrate. Now it is filtrate. Now what is the osmolarity of the blood? That is 300. Now what is the osmolarity of this filtrate? Similar to the blood, again the 300. Now what happens, beta? When this filtrate will pass through this PCT area, so in PCT, water will be reabsorbed and ions will be reabsorbed. Both will be reabsorbed. So again, the tonicity of this filtrate will be again the same, like 300. So for 300, we use the word isotonic. That is isotonic. Now what will happen? When this filtrate will come down, this area is permeable for water. So now water is reabsorbing. So which is more? Now more ion present into this fluid. So this fluid is become hypertonic. That will become hypertonic. So in descending loop of Henle, that is hypertonic. Then it is going upside. This area is permeable for ions. That is sodium, potassium, 2 chloride. So ion will absorb. So this ion is reabsorbing. What is happening, beta? This filtrate is become hypotonic. So in this ascending loop of Henle, it is hypotonic. And after this area, beta, this is depend on the condition. It can be hypertonic or it can be hypotonic. So it is ADH dependent. So this is how you identify this urine osmolarity. So it's isotonic. It's isotonic in PCT, hypertonic in descending loop of Henle, hypotonic in ascending loop of Henle, and ADH dependent in DCT and collecting duct. Next topic is clearance. What is clearance, बेटा? Clearance का मतलब क्या हुआ कि कोई भी substance इस blood के अंदर आ रहा है, इसको clear out होना है. That is called as clearance. Means amount of plasma cleared of a substance per minute. That is your clearance. And formula of clearance is equal to UV upon P. And U is urine concentration, V is rate of urine formation, and P is plasma concentration. So normal renal plasma flow is 625 ml per minute or 650. So remember, whatever things is clearing out from this glomerulus, that will be the similar like the GFR rate. जितनी GFR होगी बेटा उतना ही तो clear होगा, right? So clearance is equal to GFR. And for GFR estimating, I have told you that is best test is inulin, because inulin clearance is 125 and GFR is 125. So that is why inulin is the best method to estimate the GFR test. But if the question is asked clinically used, that is beta creatinine. So best for clinical use. बिकॉज बेटा इनुलिन इज डाई, इनुलिन तो एक डाई है, अपन डाई बाहर से दे रहे हैं और बाहर से अपन नहीं चाहते हैं कि कोई भी चीज बाहर से बॉडी के अंदर डालें. तो अपन क्या सोचते हैं कि जो कुछ भी बॉडी के अंदर है अपन उसी को ही चेक करके और अपन किडनी को चेक कर सकते हैं कि फिल्ट्रेशन प्रॉपर हो रहा है कि नहीं हो रहा है. Whatever inside the body, we can estimate this glomerular filtration with the help of this substance rather to give the outer substance, right, beta? That is why inside the body, the substance which is need to be cleared out and the rate of GFR is 125. So this substance clearance should be also nearby to the GFR. And creatinine clearance is beta 139. How much? That is 139 ml per minute. It means what is happening with the clearance? This 125 creatinine will be filtered out from the GFR due to the glomerulus, but remaining that 14 ml of creatinine later on it will be secreted out from peritubular capillary network into the tubules. So what is happening, beta? Look at over here. Suppose this 125 is clearing out from here. Now this 14 ml of creatinine is remain now over here. Now what will be happen, beta? This creatinine will be go back. Suppose this is efferent arteriole. So this 14 ml is present over here. From here this 14 ml will be secreted out into the tubule. So this is how the happen of this clearance of this creatinine. So this is GFR is also and plus secretion is also. Right, beta? That is why we always estimate the serum creatinine. And that is why for renal function test you measure serum creatinine. Right? Clearance is similar like GFR 125 per minute. For renal plasma flow, the best dye is para-aminohippuric acid, MCQ beta. For renal plasma flow, best test for renal plasma flow is para-aminohippuric acid. Inulin is equal to GFR. So only filter will be occurring. This will be only filter. Creatinine is clearance is more than GFR. So it will filter plus it will secrete. Urea clearance is around 70 beta. So what is happening with the urea? 125 it is clearing out at the level of glomerular, but it should be go out only the 70. So after that urea will be reabsorbed. So urea clearance is less than GFR. So this is filter plus reabsorbs. So this is how you should understand. And this was the question beta in your last 20th Jan FMG exam, that which is true statement. And in this question, the statement was given in the option number 1 that inulin clearance is little more than creatinine clearance, or the inulin clearance is little less than creatinine clearance. So what was the right answer of this question? Inulin clearance is 125, creatinine clearance is 139. So inulin clearance is little less than creatinine clearance. That is the right answer of that question. Next is transport of tubular max. Transport of tubular max means maximum amount of substance that can be secreted or reabsorbed per minute by the kidney. Means whatever secreting, it should be reabsorbed. So how much amount can be reabsorbed back by these tubules? This is called as transport of tubular max. Example for Tmax for the glucose is 375 milligram per minute. This is transport of tubular max of the glucose. Understanding of transport tubular max, first of all you should understand what is the filter load. Filter load nothing, beta कितना amount of substance blood के अंदर है. The substance which is present into the blood, that much is called as filter load. So this is filter load that is permanent into the tubules. So filter load is nothing. This is GFR multiplied by plasma concentration. And normal glucose filter load is 125 milligram per minute. But what will be happen, beta? If glucose will be more, it means filter load will be more. What about with the transport of maximum glucose? That will be the reduced. So what will be happen if filter load is more? This more amount of glucose will start appearing into the urine, and this condition is called as glycosuria. And if transport max is more than filter load, then no glycosuria. No glycosuria. Renal threshold. Threshold means anything which is up to some of level, it is acting very slowly, but after some time it acts very fast. This is called as threshold. So plasma concentration above which glycosuria becomes beta. Normally renal threshold is actually that is 300 milligram, but actual renal threshold is 180 milligram. So ideally up to 300 milligram glucose can be reabsorbed back, but 300 milligram. Hyperglycemia, body don't wants to take so much of glucose. Body wants to excrete out this extra glucose. So that is why the actual renal threshold is 180 milligram. And this is called as this is called as a renal splay. This is called as a renal splay. This is called as a renal splay. Remember, beta, there are 4 syndromes are there. There are 4 syndromes are there. This is your Bowman capsule. Right? If any problem occurs in this area, what will be happen, beta? No reabsorption will be occur. Suppose the channels which is present over here, they are mutated. So if any problem occurs in this reabsorption site, this condition is called as Fanconi syndrome. Fanconi syndrome. This is called as Fanconi syndrome. Number 2, if any problem occur or mutation is occur at the sodium potassium 2 chloride channel, right? And this is the ascending limb of loop of Henle. So if any problem occurs in this area, this condition is called as Barter's syndrome. If any mutation occurs of this area, so which channel over this area, beta? Which channel over this area? In this area, sodium chloride channel. So if any problem occurs in this area, this is called your Gitelman syndrome. Gitelman syndrome. And if any problem occurs in this area, so which transport over here? That is P cell or E neck channel. E neck channel. So beta, remember, in all these 3 conditions, number 1, number 2, and number 3, there is a less function of this channels. So these channel will function less. But in the 4th one, in this syndrome, in this mutation, this is a gaining function. This E neck channel will overactive, and this condition is called as Liddle's syndrome. Liddle's syndrome. So all these 3 syndromes are doing the less functions, and in E neck channel it is overactivity, and this is called as Liddle's syndrome. Right, beta? So now we already know which channels are there. So in Fanconi syndrome, kidney do not reabsorb electrolyte back. In Bartter syndrome, disorder of ascending loop of Henle, sodium water loss in urine, and there is a sodium potassium 2 chloride import. So if sodium is losing, potassium is losing, chloride is losing. What is condition? Hyponatremia, hypokalemia, hypochloremia, and also beta, this leads to hypocalcemia. But remember, serum magnesium level is normal. No effect on serum magnesium level, beta. MCQ. Serum magnesium level is normal. Always remember. In Gitelman syndrome, disorder of obesity, and this is an antibody against sodium chloride channel. So low calcium in urine and decreasing the serum magnesium level. Again MCQ. So in Gitelman syndrome, serum magnesium is less, but in Bartter syndrome, serum magnesium is normal. In Liddle syndrome, this is an increased activity of sodium channel in collecting duct. And if beta, more sodium will reabsorb, more water will reabsorb, and this will lead to the hypervolemia, and this will lead to the hypertension. So in Liddle syndrome, there is a hypertension. This is an E neck gene mutation causes hypertension. Right, beta? Next is countercurrent mechanism. In this countercurrent mechanism, this is nothing, beta. This due to the concentration urine in the kidney, high medullary osmolarity, and this osmolarity is up to 1200 milliosmol per liter. And this is due to mainly in juxtamedullary nephron due to vasa recta. This is due to vasa recta. What happens, beta? Remember, I told you in the juxtamedullary nephron there is more concentration of the urine will happen, and this is due to this countercurrent mechanism. If you remember, in the morning I told you. Look at over the screen. Beta, what happens? This urine is coming from the PCT. This is 300. Osmolarity is 300. What happens? Up to this area, water will reabsorb more and more. So what will be happen, beta? If water will be reabsorbing, what about the osmolarity? This osmolarity of this filtrate will be increased. So see, beta, it will become 600. More water reabsorb 900, and this will lead to up to the 1200. Now what happens when this filtrate will reach up to this area? At this area, ions will be reabsorbed. So if ions will be reabsorbed, what will be happen with the osmolarity? Osmolarity will be decreased. So see, 700. More ions reabsorbed 400, and ultimately it will become normal 300. Now what is happening, beta? This is the blood vessels which I told you. This is vasa recta. In vasa recta, blood is coming, and blood osmolarity again the 300 milliosmol. So now this sodium potassium chloride absorbed. This reabsorbed will be thrown into this blood vessel. So what will be happen? This blood vessel will be getting more ions. So the osmolarity of this blood vessel will be increased. So see, beta, from 300 it's 400, then 900, and up to 1200. Now what will be happen? After this time, this blood will reach into this descending loop of Henle. And what will be happen? What is the present over here? Here is the presence of this water. So what will be happen, beta? This water will be mixed into this blood vessels. And if this water will mix into this blood vessel, what will be happen? The osmolarity will be decreased. So see, 900, 600, 400, and ultimately it is 300. So this is how this countercurrent mechanism helps to reabsorb more water and more ions. That is why the loop of Henle is deeper into the medulla. That is why it is deeper into the medulla. In exam, they ask the question, countercurrent mechanism exchanger is, this is due to in vasa recta. And this is multiplier. Who is multiplier? That is sodium. Remember, beta. And this is in the thick ascending limb of loop of Henle. Thick ascending loop of Henle. Coming to the next, beta. Urinary bladder innervation. In urinary bladder innervation, beta, remember, this urinary bladder, already I told you that this will get an autonomic nervous system because this is an involuntary muscle, and autonomic nervous system is always divided into sympathetic nerve and parasympathetic nerve. Right? Into two it's divided. And always remember, parasympathetic is a craniosacral outflow and sympathetic is thoracolumbar outflow. Later on I will tell you, beta. So that is why, as you can see, this is coming from the sacrum part and supplying to the depressor muscle and also supplying to the involuntary sphincter, that is internal sphincter. Similarly, sympathetic also supplying the like this. But outer sphincter is voluntary sphincter. And if this sphincter is voluntary, beta, if this sphincter is voluntary, what will be happen? This will supply with the somatic nervous systems. This will supply to the somatic nervous systems. So this is how this bladder innervation is happens. In diabetes insipidus, I already told you there can be two possible reasons. Number one, neurogenic. Number two, nephrogenic. Neurogenic, this is due to decreased ADH from pituitary gland. And nephrogenic, ADH is normal. ADH is normal, but receptor in collecting duct not functioning. And treatment is desmopressin. This is desmopressin. Remember, beta, for the aldosterone, this aldosterone, there can be two possibilities with the aldosterone. If aldosterone is more, what is the function of the aldosterone? Suppose this is your P cell and I cell, beta. So what is the function of aldosterone? This aldosterone is coming from this backside. So what is the function? Function of this aldosterone is this will increase the innate channel activity, and this will allow to more sodium and more water reabsorption, more potassium secretion, more H ion secretions. Now, if this aldosterone is more, there can be two possibilities with aldosterone. That aldosterone can be released into more amount, more and more amount, or either it can be very less. Two possibilities can be there. So if aldosterone is more than the normal condition, this disease is called as Cohn's syndrome. This is called as Cohn's syndrome. And if this aldosterone is very less, this is called as Addison's disease. This is called as Addison's disease. And now you already know what will be happening if there is a more aldosterone and there will be less aldosterone. Right? So in Cohn's syndrome, what is happening? Aldosterone is more. Aldosterone is more. This will lead to hypernatremia, hypervolemia, hypertension, hypokalemia. Beta. Potassium will be secreted out more. So hypokalemia. And if H ion secreting more, so blood will become alkaline. So metabolic alkalosis. In Addison disease, aldosterone is less. So this will lead to hyponatremia, hypovolemia, hyperkalemia, hypotension, and metabolic. More H ion will be inside. So metabolic acidosis. With ADH, we also have seen if ADH is very less, this is lead to diabetes insipidus. But there can be another possibility. This ADH can be very high, and this syndrome is called as SIADH. Syndrome of inappropriate antidiuretic hormone. And now we have already seen what is the function of antidiuretic hormone. It will increase the water reabsorption, collecting that water permeable, hypertonic urine, low volume urine, increase specific gravity. Similarly, if ADH is absent, decrease reabsorption, less permeable for water, hypertonic urine, high volume urine, increase thrust called as polydipsia, low specific gravity. So beta, now the next topic is acid-base balance. This we will study after the lunch break, because this acid-base balance, every time there is one question come from acidosis and alkalosis, and I will give you a few tips, then you will easily understand this acid-base balance, and then only after the break we will study about this acid-base balance, because it is quite important for us. Okay, so if till now everything you understood, everything you are getting well, then it's okay. But if you find any problem, beta, just write me on the WhatsApp. I will try my best to solve it out. Okay, beta, I will try my best to sort it out. Just write me on the WhatsApp. So let's have a break, the lunch break. Right now it's 2 o'clock, and lunch break for 50 minutes. So we'll resume the class, beta, at 2:50 p.m. Okay, beta, 2:50 p.m. So resume at 2:50 p.m. Okay, thank you very much. So welcome back after the break, beta. I hope I'm properly audible and properly visible. So let's start with the acid-base balance. Before the break, we have talked about the Cohn's syndrome, about the Addison disease, about the diabetes insipidus, CR syndrome, and we have seen that for regulation of this GFR, glomerular filtration rate, we require two main hormones. That is number one, your ADH, aldosterone, and also we require the renin, right? So all these three hormones actually functions on this kidney for making more concentrated urine or more dilated urine, right? In the break, one student asked me, sir, how the hypokalemia is happening? In Cohn's disease, so it will lead to metabolic acidosis. But remember, look at on the screen. Suppose this is your collecting duct, right? In this collecting duct is actually made up of the cells. So like this, there is a cells. Right, similarly over here, this is also cells, right? So what happens? I told you what is the function of aldosterone. Suppose this is the blood vessels, right? Now what is happening? This aldosterone is coming from this blood, right? Suppose this is the aldosterone, and then it is coming over here and binding with the receptor which is present on the P cell. Now what is happening? When this binding with the P cells on the receptor on the P cells, what is happening? There is a channel which is called as ENaC channel, and this ENaC channel is opens, and what happens? The sodium which is present over here, this starts coming inside of the cell, and then ultimately it's goes into the blood, right? Now similarly, when the sodium comes inside, the potassium which is present inside, that will go outside into the tubules. So this is called as potassium secretion, right? Similarly, from this I cell, H ion is also getting out. How much potassium? I already told you, H ion is always follows the potassium. So if the potassium is going out, H ion will also go out, right? So this is how this hypokalemia, less potassium, then it leads to hypokalemia, because this potassium is leaking out into the urine. So this will lead to hypokalemia. And similarly, the H ion, but remember this H ion is acidic in nature. H ion acidic in nature. So what is happening? If this H ion is going out, if this H ion is going also out, what is happening? It will lead this to metabolic alkalosis, because more acid is going out. So it will lead to metabolic alkalosis, and this was the question of that students. Wait me, let me check. Yes, beta. So this is metabolic alkalosis, and the similar things I have mentioned in this Cohn's disease. See, beta, in Cohn's I have mentioned this is metabolic alkalosis, and in addition I have mentioned this is metabolic acidosis. Right? So I hope now it is clear. Coming to the acid-base balance. For understanding this acid-base balance, remember this acid-base balance having a scale from 1 to 40. This 7 is neutral. So below the 7, that is acidic. More than 7, that is alkalosis. Right? That is alkaline. Remember, water is having 7 pH, so it is neutral. Neither acidosis nor alkalosis. Right? Normal pH of the blood is always, remember, this is 7.35 to 7.45. So now you know that blood is slightly alkaline in nature. So this is the normal value 7.35 to 7.45. But remember, for understanding this acidosis alkalosis, you have to remember only those two things. Number one, that is PaCO2, and number two is HCO3 minus, that is bicarbonate. Remember, this PaCO2 is always acidic in nature and bicarbonate is always alkaline in nature. CO2 acidic, bicarbonate alkaline. Normal value of this PaCO2 is 35 to 45 and bicarbonate is 22 to 28 mmHg. This is milli equivalent per liter. This is acidic and this is alkaline in nature. So now, now you know that what would be happen. So this is the normal pH, that is 7.35 to 7.45, that is normal pH. More than 7.45 pH, then it is acid. This is alkalosis. Less than 7.35, this is acidosis. So now just forget this 7. Now just remember, this is the mean value because we are checking the pH of the blood. So we are checking the mean value of this blood, and the mean value of this blood is 7.35 to 7.45. Less than 7.35, that is acidosis. More than 7.45, that is alkalosis. So just watching the pH, you can easily rule out the two questions. Number one, that is either it is acidosis or alkalosis. So now question comes whether it is respiratory or whether it is metabolic, right? So always remember, then these two values, PaCO2, that is 35 to 45 normal, and bicarbonate is 22 to 28. PaCO2 is acidic in nature, bicarbonate is alkaline in nature. Now always remember, PaCO2 is indicator of the respirations because CO2 gas you always wash out from the ventilation from the lungs, and bicarbonate it is also forms from the CO2, and this bicarbonate actually excrete out from the kidney. So that is why for PaCO2 we use the word respiratory because it is indicator for the lung, and bicarbonate is indicator for the kidney. So hence we use the word metabolic. So anytime whenever the CO2 is culprit, then you have to say that is respiratory, and if culprit is bicarbonate, then you have to say this is a metabolic, right? Beta? Remember what happens. Suppose if any patient comes to pH value is 7.2, PaCO2 is 60, and bicarbonate is 26, right? Beta? Bicarbonate is 26. Now what happens? Just watching the 7.2 pH, that is acidic in nature. How will solve the question? Beta? Remember very carefully. This is acidosis. So this is acidosis, right? Now this is normal or not? PaCO2. PaCO2 beta 35 to 45 is normal. This is higher, and higher means more CO2 means this is acidic in nature. So this will lead to acidosis. This is normal or not? This is absolutely normal. This is absolutely normal. And if this is absolutely normal, it means who is the culprit? Beta? Who is the culprit? This PaCO2 is the culprit. So it means this PaCO2 is leading to this blood into the acidic in nature. So for CO2 we use the word respiratory. So this is your respiratory acidosis. Respiratory acidosis. Let's do the one more equation. Suppose pH 7.1, PaCO2 is 43, and bicarbonate is 5. Now this is acidic in nature. This is acidosis. This is normal, and this is less. Less bicarbonate means beta, this is alkaline in nature. It means alkaline is going to the down. So if alkaline is less, blood will become more acidic. So who is the culprit? Culprit is bicarbonate. So this will cause that bicarbonate. We use the word metabolic. So this is metabolic acidosis. Metabolic acidosis. Let's do one more equation. pH 7.6, CO2 39, bicarbonate is 39. Or suppose this is in alkalosis, this is normal, this is more, it means it lead to the alkalosis. Who is the culprit? Bicarbonate is the culprit. What is happening? This is your metabolic alkalosis. So but always remember, whenever you just find this such type of questions, only 3 major values required. If they are mentioning about oxygen, they are mentioning about nitrogen, no required any of the value. You require only these 3 values. Number 1, that is pH, number 2 CO2, number 3 is bicarbonate. And always remember, bicarbonate is acidic, alkaline in nature, CO2 is acidic in nature. Just by watching the pH of the blood, 7.35 to 45, that is normal. If more than 7.45, that is alkalosis, less than 7.35, acidosis, and then find the culprit. So this is how you can easily calculate this acidosis alkalosis question. Now let me check. pH is 7.58, CO2 is 20, bicarbonate is 24. Now tell me, beta. Now tell me in the comment box. Now tell me in the group what is this condition. Please tell me on the WhatsApp group what is this condition. Answer me in the group, beta. Answer me in the WhatsApp group. What is this condition? pH is 7.8, 7.58, CO2 is 20, and bicarbonate is 24. What is this? What is this? Why this is some name, beta? Just me, beta. No, this is not metabolic alkalosis. No, beta. No. Respiratory acidosis, Simran. Why this is acidosis, beta? This is not acidosis, this is 58. See, if 7.58 more than 7.45, alkalosis. So this is alkalosis. This is not the acidosis. Yes, Sandeep. Yes, Sandeep, perfectly. This is respiratory alkalosis. Yes. This is yes. Subramaniam. Yes, Shweta. Yes. Yes, just me now you corrected. Okay, well done, beta. Oh yes, YV respiratory alkalosis. Mani, Akshay. Always be happy. Yes, everybody, you are right, beta. This is normal condition. This is normal condition. This is less. It means alkalosis. Blood is also alkalosis. So who's the culprit? Culprit is CO2. Yes, beta. CO2. Yes, Avinash. Very good, beta. CO2 is the culprit. Very good, beta. Let's do one more equation. pH 7.0, CO2 44, bicarbonate is 12. Now tell me, beta. Now answer me. What is this? Now answer me. Answer me for the second example. Yes, answer me, beta. Answer me. Yes, Simran. Yes, Sandeep. Shweta. Yes, beta. Very good, beta. Very good. Well done, beta. Well done. Yes, beta. Metabolic acidosis. Very good. All of you are right, beta. All of you are right. Very good, beta. Sudarshan. Yes, Anu. Always be happy. Yes, beta. Everyone. Shweta. Yes, beta. Everyone, you are right, beta. Very good, beta. So very good, beta. Yes, beta. This is normal condition. This is the culprit. This is into acidosis. It means this is also less, leading to acidosis. So this is metabolic acidosis. Very good, beta. This is metabolic acidosis. Can we do one more? Can we do one more, beta? Yes, let's do. pH is 7.7. CO2 and bicarbonate. CO2 is 37. Bicarbonate is 66. Now tell me, beta. Now tell me. Now tell me, beta. What is this? What is this condition? 7.7 pH. CO2 is 37. Bicarbonate is 66. Yes. Well done, beta. Yes, beta. Well done. Well done. A big clap for all of you, beta. Very big clap. Now you all are right, beta. Yes, well done. Well done, my students. Well done. So this is how, beta, you can easily answer that. So see, respiratory acidosis, metabolic acidosis, this acid-base balance is quite easy to answer, isn't it? Yes, beta. All of you are right. Well done. Yes, beta. Metabolic. No, beta. This is last one. Who is this? Ek aisi shakhsiyat, beta. But I don't know the name of you, beta. You have not mentioned. This is not acidic. This is alkalosis. Yes, beta. Everyone. Avinash. Yes. Everyone. You are right, beta. Metabolic alkalosis. Very good, beta. This is metabolic alkalosis. Very good. Beta. Can we do one more? Do you want one more, beta? Please write me in the chat box, beta. Do you want one more example? Or shall we start? One more? Okay. Now tell me, beta. Okay, tell me. pH is 6.5. CO2 and bicarbonate. pH is 6.5. CO2. Now, this CO2 is 70 and bicarbonate is 28. Now tell me, beta. Now tell me. What is the answer? Beta? Yes, everyone, you are right. Who is the culprit, beta? Who is the culprit? This is normal. Who is the culprit? CO2 is culprit. What is happening? This is acidic, and this is also leading to acidic. Who is culprit? Culprit is CO2. So this is your respiratory acidosis. This is what, beta? Respiratory acidosis. Very good, beta. Very good. Everyone, beta. This is respiratory acidosis. Well done, beta. Well done. Let's have a big clap for all of you guys, beta. Very good. All of you are answering perfectly right, beta. Yes, respiratory acidosis. So now I hope, beta, if this question will come in the exam, definitely you are going to mark it right or correctly, beta. I hope so. Yes. So now let's start writing, beta. This regulatory mechanism of this acid-base balance, number one, that is buffers. Buffers are nothing but they are fastest acting, and they, whatever is very fast, this is for very short period. So this is very shortest also. When acidosis is there, H ion will be donated. When alkalosis will be there, OH ion will be excreted. Right, beta? Now what happens? In the lungs indicator is CO2. We already know that. And acidosis removes the CO2 and water. And kidney, for kidney we use bicarbonate. That is lactic but better efficacy. PuCO2 is respiratory indicator. That is respiratory indicator. And bicarbonate is metabolic indicator. Whenever the CO2 will be high, pH will be decreased. CO2 will be decreased, pH will be more. Bicarbonate will be high, pH will be high. Bicarbonate will decrease, pH will decrease. Yes, beta? Now coming to the next, beta, that is anion gap. What is the anion gap? Anion gap is nothing. In extracellular fluid, there are two types of ions present in extracellular fluid. Number one, that is positive ion. Number two, that is negative ion. So difference between this positive and negative ions, that is called as anion gap. So what are the positive ions present in the ECF? In the ECF, beta, what are the positive ions? Positive ions, there is sodium. And negative ions, that is number one, chlorine. Number two, bicarbonate. Right, beta? Negative ion, chlorine and bicarbonate. So sodium value, you always know, that is around 140 is the normal value. For chlorine, that is 104. Bicarbonate, already you know, this is around mean 22 to 28. So mean we can calculate this is 26. So this is difference between positive to negative ion. So how much difference? 140 minus 130. This is total 10. So this is called as anion gap. This is your anion gap. So anion gap is nothing but anion gap is difference between negative and positive charge electrolyte in your ECF or blood or in blood. Right, beta? Normal anion gap is 6 to 14. Normal anion gap is 6 to 14. Right? Normal anion gap is 6 to 14. Coming to the glucose transporter. Glucose transporter is two type, beta. Number one, that is GLUT. Yesterday we already talked about. Number two is SGLT. This GLUT are different type. GLUT1 is present into your RBC, then blood-brain barrier, then kidney, and this is insulin independent. Number two, GLUT2 in liver, pancreas, beta cell, beta, and small intestine, also insulin independent. GLUT3 again in brain, neurons, and placenta, again insulin independent. All right. Then GLUT4, and this is for exam purpose, beta. Remember, this is your skeletal muscle, adipose tissue, and heart, and this is insulin dependent. GLUT5 for fructose, I already told you. So this is present in enterocyte of intestinal luminal, and this is for juvenile side, insulin dependent, and this is for fructose transporter. Remember, beta, this is for fructose transporter. Right? SGLT1 in enterocyte of intestinal epithelium again, and this is in intestine SGLT1. Right? So this is in intestine, and SGLT2 in kidney, so proximal tubule of nephron. So this is how, beta, all about this kidney. I hope that let's do this exercise questions. And in exercise questions, number one, all are true about juxtamedullary nephron. Except they are consist about 50% of nephron. That is true. Glomerular size is small. No, glomerular size is large. That is false. Responsible for counter current mechanism. True. Rate of filtration is high. That is true. So right answer is B. All are part of renal tubules except Bowman capsule, TCT, collecting duct. It means glomerulus is not a part of renal tubules. In which part sodium reabsorbs with the help of P cell of maintain body electrolyte balance? This is in the collecting ducts. In which area? Collecting ducts. नॉर्मल नेट फिल्ट्रेशन प्रेशर बेटा एनएफपी में क्या बात करी थी अपन ने, ग्लोमेरुलर हाइड्रोस्टेटिक प्रेशर माइनस ब्लड क्लोराइड ऑनकोटिक प्रेशर प्लस कैप्सुलर हाइड्रोस्टेटिक प्रेशर, एंड व्हाट वाज द नॉर्मल 10 to 20 mmHg. So the right answer of this question is 15 mmHg. EPO releases by kidney to produce new blood cells. Identify which cell produce EPO beta. This is your interstitial cell. This is your interstitial cell. Right. So this is all about your this excretory systems beta. Now coming to the next, that is your respiratory system. That is your respiratory systems. So let's start with the respiratory system. Yes, beta, again the respiratory systems. So can we do one more acidosis alkalosis question, beta? Let's do it. Now tell me, beta. pH is 7.1, CO2 is 44, bicarbonate is 14. Now tell me, what is the answer? What is the answer, beta? What is the answer of this question? Now answer me, beta. pH 7.1, CO2 44, bicarbonate is 14. Metabolic? Yes, beta, that is metabolic acidosis. Well done, beta, well done. All are guys very great. Very good, beta. That is metabolic acidosis. Yes, culprit is bicarbonate. Yes, beta, very good. Everyone, Srishti, Simran, Avinash, Sandeep, Yelevi, that's Akshit, Sudarshan, Bhavika. Yes, beta, everyone you are right, beta. Everyone you are right. This is your, yes, beta. Yes, everyone you are right. That is metabolic acidosis. Okay, metabolic acidosis. Why? This is the culprit. This is leading to acidosis. This is normal, and this is in acidic condition. So who is the culprit? Bicarbonate is the culprit. Okay, bicarbonate is the culprit. Right, beta? So this is how you should answer this question. Now next is, but if pH CO2 and bicarbonate will be normal, Sudarshan, then there will be no changes in the pH of the blood. The pH of the blood will also be normal, because who is maintaining this pH of the blood? This pH of the blood is actually maintained by the CO2 and this bicarbonate. Okay, beta? So if pH CO2 and bicarbonate is normal, then pH will be normal. There will be no change in the pH. Always remember, right? Why the pH is changing? Because the value of pH CO2 and bicarbonate is changing. Now coming to this, medico, beta, I don't know, beta, your names are something like, you never write down your names. No, beta, when pH is normal, bicarbonate and CO2 cannot be in abnormal condition. No, this is not a right question. Anu, when pH is normal, both bicarbonate and CO2 are abnormal. No, never. Bicarbonate and CO2 will always be in the normal condition. Let's see what is happening. Suppose in your house everything is normal. When the condition will be abnormal, when either you are not listening to your parents, or either your brother or sister is not listening to your parents. So somebody should be culprit in your house. Otherwise, everything will be keep and quiet, and everything will be perfect and fine in your house. So similarly, inside the body, if CO2 and bicarbonate is normal, no problem with the pH. pH is also will be normal. Okay, beta? So this is condition. So let's move on this respiratory system. In respiratory system, this is system with organs consisting. The respiratory system is from nose up to the lungs. In lungs, there is an alveoli. So lung, nose, pharynx, larynx, trachea, bronchus, bronchiole, alveolar duct, sac, and alveoli in lungs. Right, beta? The lungs, you know, that is the one pair and situated in the thoracic chamber. And what is the function of this respiratory system? Function of this respiratory system is nothing. This is for doing the ventilation and doing all the gas exchange. Right, beta? This is the function of the lungs. Also, as right now only you the seen, this is also for maintain the acid-base balance of the body. Right? These lungs are present inside of this thoracic chamber. And this thoracic chamber is a tight chamber. Thoracic chamber, ventral means aage. Ventral means aage. In front. Ventral means in front. Dorsal means piche, back side. So in ventral, you know that is which one this is. This is your sternum. So this is sternum and ribs. Dorsally there is vertical column and ribs. Laterally this is your ribs, and this is your anteriorly side, neck and clavicle, and posteriorly but this is below area. Below area, you know there is a dome shape, because this is your lungs, right? This is your lungs, right? And below area is something like this. This is a dome shape, and this is your called as diaphragm. What is this? Diaphragm. This diaphragm is actually made up of what? This diaphragm is made up of what? This is made up of the muscle. And which muscle? Phrenic muscle. So this is how your thoracic chamber is situated. In your lower posterior chamber, that is diaphragm, dome shape, anterior is neck and clavicle. There is something called the Boyle's law. What is the Boyle's law? For understanding the Boyle's law is quite simple. Understand that this is inversely proportional for the pressure. Volume is inversely proportional for the pressure, or pressure is inversely proportional for the volume. What is the Boyle's law? But remember, if you are expanding, for suppose this is the glass. If I make it a closed glass like this, now if I change the diameter, or if I increase the size of this glass, so volume will be increased. What will be happen? Whatever air present inside this glass, what about the pressure? Pressure will be decreased or increase? Pressure will be decreased. So if you will increase the volume, pressure will be decreased. But if you will decrease the volume, if I squeeze this glass more and more, what will be happen? The pressure will be increased, and this is called as Boyle's law. Boyle's law ने कहा pressure is decreased, volume is decreased, pressure is increased, volume is increased, pressure is decreased. This is called as Boyle's law. Coming to the next, that is lungs. In the lungs, understanding for this airway classification, for this all airway tract, there is called as Weber airway classification. First of all, you should identify, because inside of the body, everything started from the cell. So this complete lungs is also originated from one of the smallest structure, first of all. And this is how it generated. So first it made by this trachea. Then this trachea, they are going on like this. They are bifurcating. And this bifurcation is called as your bronchus. If I am talking about two things, then this is bronchus. And if we are talking about the plural, then it is bronchi. So if singular, then this is bronchus. If plural, that is bronchi. So this is then bronchus, called as primary bronchus. Then you know, inside of the right lung, there is a 3 lobe. In left lung, there is a 2 lobe. So right now, this bronchus is dividing into one lobe, another lobe, and third lobe like this. So now this bronchus, primary bronchus, will convert it into secondary bronchus. Then the secondary bronchus originated, then becomes the tertiary bronchus. Then this tertiary bronchus, again this windpipe is going to be smallest, and this smallest pipe now we call this as a bronchiole. Like in the artery, we call that arteriole. So similarly, this bronchus now called as bronchiole, and this is starting from the initial bronchiole, and in the last beta, it makes the primary terminal bronchiole. So similarly, this is making, going like this, and in the last, this is your terminal bronchiole. What happens, beta? After this terminal bronchiole, there is starting of the respiratory bronchiole. Starting of the respiratory bronchiole. Then this respiratory bronchiole started and then makes the alveolar duct and making the alveolar sac. And in alveolar sac there is a alveoli like this. There is a alveoli. Remember, beta, from this trachea up to this terminal bronchiole, no air exchange is occurs. So it means from trachea, this air entering inside of your lungs up to the terminal bronchiole, no air exchange occurs. When the air exchange will start, beta? Air exchange will start from this respiratory bronchiole up to the alveoli. So that is why from trachea up to this terminal bronchiole, only airway pass through this area. So that is why we use the word conduction zone. Airway conduction zone. So from trachea up to the trachea up to the terminal bronchiole, this is called as your conduction zone. Then from respiratory bronchiole up to the alveoli, we use the word exchange zone. Right, beta? So what happens? First of all, your trachea was originated. So this we have given the zero generation. Then the primary bronchus will be generated. We have given the first generation, and then it's going and going and going and going. And last, this is the alveoli. This is the alveoli. And for the alveoli, we use the word, this is the last generation of origination. And this is the 23rd generation. So this Weber's airway classification is based on 23 generation, total 23 generations. For exam point of view, you have to remember trachea is 0 generation, terminal bronchiole is 16th generation, respiratory bronchiole 17th generation, and alveoli is your 23rd generation. Alveoli is 23rd generation. Next is trachea. But remember this trachea, primary bronchus, secondary bronchus, tertiary bronchus, initial bronchiole, and also make the correction up to here. This is not up to here. This is up to here. This is the terminal bronchiole, and up to this level, this is called your conduction zone. This is called your conduction zone. Right? After this area, after this terminal bronchiole, there is a respiratory bronchiole, then alveolar duct, alveolar sac, and alveoli. And this is called your exchange zone or exchange part. This is called your exchange zone or exchange part. It's lagging, I think, yeah. So this is your exchange zone, right? Now, next, trachea. Coming to the point of trachea. Trachea is present anteriorly, length is 10 cm and width is 2 to 2.5 cm. Epithelium is PSCCGE. What is PSCCGE? Pseudo stratified. Stratified means they are transverse line, but these transverse lines are not actual, but they are false. For false, we use the word pseudo. So they are called as pseudo stratified. Columnar, ciliated columnar. That is ciliated columnar glandular epithelium. What is the meaning of ciliated? But remember, what is the cilia? Cilia function is nothing. Cilia actually removes all the mucus production happening inside of your lungs. So this is coming out against the gravity. What happens, beta? When this cilia actually functions with the help of a protein called as dynein. The cilia functions with the help of dynein. During the intrauterine life, all our organ during intrauterine life actually they forms to the opposite side. Then after development, the organs comes to the opposite side, and this is how our organ development occurs. What happens? Suppose if a baby is having no cilia is there, or cilia is immobile. So cilia is immobile due to absence of dynein protein, and if dynein protein is absent, the cilia become immobile. So if cilia become immobile due to the dynein protein, this is called your Carter-Genner syndrome. This is called your Carter-Genner syndrome. And this Carter-Genner syndrome, there is a triad. What is the triad? Number one, this heart is actually developed this side, but the cilia is immobile, so this heart will not come to this side after development. So what is happening? This heart is present onto this side only. And if this side heart is present, this is called as your dextrocardia or situs inversus. Right? So number one, that is dextrocardia. Number two, also there cannot be, this mucus will not come out. So your area, this conduction area will become dilated, bronchioles will become dilated, and this condition is called as bronchiectasis. And similarly, here is the sinuses. This sinuses also will be inflamed, so called as sinusitis. So this is the triad of this Carter-Genner syndrome. This is the triad of this Carter-Genner syndrome. Always remember. And this is due to the absence of this dynein protein into the cilia. There is the presence of cartilaginous rings that are C-shaped, and to this prevent the collapse of this trachea. Bifurcation is T5, T6. Bronchial trees, but this is not 10, this is primary. This is primary bronchus to terminal bronchiole, and respiratory trees from terminal bronchiole to alveoli. Right? Next is respiratory tract. But from nose up to the larynx, this is called as upper respiratory tract, and from this larynx up to the alveoli or up to the lungs, this is called as lower respiratory tract. Remember, in trachea, there is a PSCCGE, pseudostratified ciliated columnar glandular epithelium, and size of this 2 to 2.5 centimeter. Bronchi is again PSCCGE, size little less. Bronchial to terminal bronchiole, simple columnar ciliated. Respiratory bronchial, simple cuboidal, and this is ciliated again. Then alveolar duct, simple squamous, non-ciliated, and in alveolus again, simple squamous and non-ciliated. And size of this alveoli is 0.5 mm. So it's less than 0.5 mm. This alveolus is size 0.025 mm, structure and function rate of the lungs, and there are 300 million in the lungs. So if singular alveolus, plural alveoli, right, beta? Coming to the first part, that is cell. So which cell present into this lungs? So for lungs, there are air is coming. For air, we use the word pneumo. So cell which is present into the lungs, we call as pneumocyte. And there are two types of pneumocyte, type 1, and type 2. That is your type 2, right, beta? Suppose this is your alveoli, right? This is your alveoli. In your alveoli, one cell is present like this, okay, and another cell is present like this. So now please, beta, tell me which cell is most abundant inside of your lung. This is your type 2 and this is your type 1. Which cell is most abundant? Most abundant means more in numbers. Which is more in number? That is type 2, and that is why type 2 is most abundant pneumocytes. Type 1, this is bigger in size, so surface area is bigger. So this is most abundant surface area. That is type 1 pneumocyte. This is how an exam question can be asked. Always remember. So this is maximum surface area. This is most abundant. What is the function of this type 1 pneumocyte? Type 1 pneumocyte function is nothing. The oxygen will come, this will enter inside of this pneumocyte, and now then it will deliver into the blood vessels. So this is the function of this type 1 pneumocyte, right? Coming to the next part, that is type 2 pneumocyte. What is the function of type 2 pneumocyte? Type 2 pneumocyte actually secretes a surfactant. What it secretes? It secretes the surfactant. It secretes the surfactant. Type 1 pneumocytes, gas exchange. Type 2 pneumocyte secretes the surfactant, right? Now, this is for gas exchange. This is for secret surfactant. There are some other cells also, like Clara cells, which are progenitor cells. Then Kuchitsky cell and dust cell. Dust cells are macrophages of the lungs. Macrophages of lung. Everything inside the body is made up of only three things. Number one, protein. Number two, lipid. Number three, carbohydrate. Inside everything is made up of the protein. So now the surfactant we require for smoothing the area, and for smoothing we require the oil, and oil is made up of the lipid, fat. So this surfactant is also made up of the fat, and this is called as dipalmitic oil. Dipalmitic oil. Phosphatidine. Dipalmityl phosphatidine. Choline or DPPC. DPPC. Also known as lecithin. Very important question. This reduces the surface tension of the lungs. So what is the role of surfactant? Reduce the surface tension. Question comes, when the surfactant start producing during intrauterine life. But remember, it starts producing in the MCQ week, 20th intrauterine life week. But it starts appearing in amniotic fluid from 28 to 32 week. From 28 to 32 week. That is in 7th month, and that is in intrauterine life. But that is why there is a premature delivery before the 28th week. You can't stop. That's where there is a type 2 pneumocyte is already developed or not. What will be happen if this type 2 pneumocyte is not developed? Surfactant is not there, so your alveoli cannot be expanded. They cannot be inflated. And once the alveoli cannot be inflated, this baby cannot breathe properly, and this can lead to the respiratory distress syndrome. What we call as respiratory distress syndrome, and this disease is called as hyaline membrane disease. So surfactant is not there. This disease is called as hyaline membrane disease. This surfactant is degraded by GM-CSF, granulocyte macrophage colony stimulating factor, because it is continuously producing, continuously remove out, producing, remove out, producing, remove out. Right? There is the presence of J receptor which is present on the alveoli of reflex supplied by the vagus nerve. Vagus nerve. Coming to the next part, that is breathing. In breathing means ventilation. So again, this is the Boyle's law. This is the Boyle's law. Volume is inversely proportional to the pressure, and this process of breathing can be two types. Number one, that is inhalation. Number two, exhalation. Now the question comes: how this inhalation is occurs? How this inhalation is occurs? Remember, this inhalation is occurs like this. What happens? Normally, when I am sitting over here, so over here there is a barometric pressure. There is a barometric pressure or atmospheric pressure. This atmospheric pressure is always 760. How much? 760. Out of the 760, 78% is normal, is nitrogen, and 21% is oxygen. So in 760 mmHg, there is 78% is nitrogen, 21% is oxygen. Now you know that. That is why in the normal environment, this nitrogen is always going inside and then coming out without utilization. But oxygen will require for the metabolism for producing the ATPs. Right? Now what happens? How much is the 760? 760 78% now? It is around 470 mmHg. So this is the partial pressure of the nitrogen in the air. Similarly for the oxygen, 21%, 760 at 21% is now 159 mmHg. So 159 mmHg oxygen is there in the environment. Now what happens? Inside of the body, you know that oxygen level is always 100. Because in the COVID time, you have used the pulse oximeter and you always check your saturation. It always comes around the 90, 92, 94, 95. Now this is 159 mmHg. What happens beta? Outside 159, inside 100. It means you always know that it always gases goes from high to low side. So that is why oxygen always go from outside to inside. Now what happens about the CO2? CO2 partial pressure is around 0.03% mmHg. It means this CO2 is less in environment, and inside of the CO2 you already know that is 35 to 45, and this 35 to 45, that is why the CO2 always goes out. So this is how you should understand. One more thing. What happens beta? Suppose this is your lungs. This is your lungs, right? This is 760 mmHg. 760 mmHg. This 760 mmHg, how the 760 mmHg will start coming inside of this lung? So this 760 mmHg should come inside of the lung. How it can come inside? But always remember how this air moves from one side to another side due to the pressure. What happens? When you expand the area of this chest, why doing the muscle contraction? How the muscle contraction can be done? Suppose this is the diaphragm, but this is the diaphragm, and this diaphragm, this is the normal condition. What you can do, if this diaphragm right now in the dome shape, for increasing the space, what you can do, beta? You can just contract this diaphragm, and once you will contract, it will be straight down like this. And once this diaphragm will be straight down, what will be happen? This lungs will get more space to expand, and once this area get most area for expand up, the volume is increased, so pressure will be decreased. So that is why during inspiration, normally that is minus 760, but during inspiration, this will become 759. So there is a 1 mmHg is changes occurring. So that is why the air comes from outside to inside. Now what happens, beta? This air is coming, and again it will become from 769 to 760. So then air stops entering inside the lung. Now you have to do the exhalation. So now what you can do, beta? You have just contracted this muscle. You can do the relaxation. This is your contraction. Do the relaxation. Once you will do the relaxation, what will be happen? This diaphragm will go up, and this will reduce the volume of this lungs. And similarly, here is the external intercostal muscle. This external intercostal muscle also you have contracted. So now you just relax these muscles, so that chest will also go back. And again inside this recoiling, due to this, there is a pressure inside of this thoracic chamber. Due to this, there is a lungs recoiling, and that is why when you decrease the volume, pressure will be increased. So now due to the relaxation of this muscle, this pressure will become 761. So outside 760, inside it becomes 761, where this air will go from inside to outside. So that is how the respiration is happening. Now question comes: this inspiration and expiration, which is the active process? Both are, or none of them, or one of them is active process. But remember, whenever you require to contract the muscle contraction is using of the ATP, and that is why this is called as your active process. That is your active process. And for relaxation, or for sleeping, or for doing that exhalation, what you can do, beta? What you can do? Simply you just relax the muscle. So if you are doing the relaxation, no energy is required. This is your passive movement. But if you want to become the Baba Ramdev, what you want? You want more exhale out the air. You want to do the forceful exhalation. So how the forceful exhalation can be done? When you will squeeze out your lungs like this. And how you can squeeze out? Now inside of this costa, there is an internal muscle, internal intercostal muscle. This will contract. Once this will contract, this will pull back this ribs inside of the chest. And once this ribs will come inside, this will create the pressure on the lungs and the air will get out forcefully. Now similarly, this abdominal muscle, this is also, you just contract it. And once you will contract it, this will reduce the area and increase the pressure and air goes out forcefully. So this is how this is again an active process. So now inhalation, it's an active process. Use ATP. It is due to negative inside pressure. Intrapulmonary pressure is less than air pressure. Muscle uses diaphragmatic and extraintercostal muscle, and their function is contraction. Contraction. Then exhalation is no use of ATP, and muscle use again diaphragm, extraintercostal muscle. That is your relaxation. That you are doing relaxation. For forceful exhalation, uses ATP. Now the muscle is abdominal and intercostal muscle, and this is contraction again. Like sneezing, coughing, muscle and everything. Accessory muscles are sternocleidomastoid, scalene muscle. There is something called shunt. Shunt means nothing बेटा. जब गंदी नदी का पानी साफ नदी से मिल जाए, this is called as shunt. Deoxygenated blood mixed with oxygenated blood, this is called as shunt. So deoxygenated blood mixed with oxygenated blood. So the inspiration step is number 1, diaphragm and extraintercostal muscle that will contract. That will increase the volume of thoracic chamber simply for increase the volume of pulmonary cavity, decrease pulmonary pressure in pulmonary cavity. Cut it down, beta. Cut it down, right? And air enters inside the atmosphere. Then during expiration, this diaphragm and extraintercostal muscle that will be relaxed. So relaxation, that will be relaxation. Simply decrease the volume of thoracic cavity and pulmonary cavity, increase the pressure in pulmonary cavity, and expulsion of air from the lung to air. For forceful expiration step, abdominal and internal intercostal muscle that will again the contraction. Decrease volume plus thoracic cavity and pulmonary cavity. Increase, this will make the correction. Decrease, no, this is not decrease, this is increase pressure in pulmonary cavity and air out from the lung to air. Right, beta? Coming to the next, and that is different types of breathing patterns. First of all, what is the meaning of tachypnea and hyperpnea? What is the meaning of tachypnea and hyperpnea? Both are same or both are different things? Number 1, tachypnea and hyperpnea. Both are same condition or both are different condition? Write me down, beta. Write me in the box. What is the meaning of this tachypnea and hyperpnea? Write me in the group, beta. What do you understand about the tachypnea and hyperpnea? Anybody? Tell me, beta. Both are different. Yes, beta. Yes, Sandeep. Yes, these are different. Yes, Harry. Beta, see, if you will increase the rate of the respiration, like you are doing like this, respirations like this. Suppose this is your normal respirations, inspiration, expiration, inspiration, expiration, right? Now, what could happen, beta? If you will increase the rate of respirations, like this. So as you can see, this one and this one, this is your tachypnea. And if you will increase the depth of respiration, like this. This is your hyperpnea. So hyperpnea means increase the depth, tachypnea means increase the rate. Basis of this, you are having different type of breathing pattern. Similarly, this is bradypnea, as you can see, beta. This is the normal condition, and this is your slower condition a little bit. So that is your bradypnea. Then this is increase the rate, so tachypnea. This is increase the depth, hyperpnea. This is increase the depth, hyperpnea. Now coming to this part. This is quite important chart. Just remember beta, this part. Number 1, that is Cheney stocks. What is happening in the Cheney stocks? When breathing gradually increases and gradually decreases, and then with a pause. This is called your Cheney stocks breathing pattern. Which pattern, beta? Cheney stocks breathing pattern. Cheney stocks, right? What is happening? Normal inspiration. You are doing something like this. First respiration, second, third, like this, and then again gradually you are decreasing, then the pause. So this is called as Cheney stocks. If there is no any connection in between these patterns, means sometimes this is tachypnea or bradypnea, or sometimes it is very short breathing, then again this is long breathing, so you can't find any be normal pattern. That is called as Biot's breathing. That is your Biot's breathing. Kussmaul breathing is nothing. When the tachypnea and hyperpnea both are together, means like this, you are doing something like this. This is your Kussmaul's breathing. And then the apneustic breathing, what is happening, beta? The inspiration is prolonged. So means how it is happening? Inspiration is prolonged, expiration is short. This is prolonged, short, prolonged, short, prolonged, short, prolonged, short. Like this, it is showing like this. So now you can see this is something looking like a fish mouth or fish teeth. So this is called as a sawtooth pattern. It's called as sawtooth pattern. Sawtooth pattern ECG, and this is seen in apneustic breathing pattern. This is seen in apneustic breathing pattern. Coming to the next, that is respiratory volume and capacities, beta. In respiratory volume and capacities, these measures via the spirometry. Have you seen the spirometry, beta? There were the 3 balls which you are blowing through your mouth, and these balls is going up and down. This is called the spirometry. Understanding of this respiratory volume and capacity, understanding on this graph, beta. Suppose you are doing the normal inspiration like this, inspiration, expiration, inspiration, expiration, inspiration, expiration. So if you are doing the normal inspiration and expiration, beta, this is called your tidal volume. The air volume which you are taking inside, that is your tidal volume. Suppose if I ask you after doing the normal inspiration, if I ask you do the more inspiration, can you do this like this? So this is again you can do the more inspiration like this, and after some times you will again drop down to the normal condition. So this is called as your inspiratory capacity. This is called your inspiratory capacity or inspiratory reserve volume, or either you can say this is inspiratory reserve volume because this is the reserve condition. Similarly, after doing the normal exhalation, can I ask you to do the more exhalation? So again you can do the more exhalation. Yes, beta, you can do. So this is the more exhalation. This is more exhalation, and then it will become again to the normal. So this is called your expiratory reserve volume. But beta, always remember there is some air always remain into the lungs, and this air is always present into the lungs called as residual volume. This is called as residual volume. Now question comes. Now question comes. What is the question? This area, this tidal volume plus inspiratory reserve volume, combinedly can I call it the inspiratory capacity? That is called as total inspiratory capacity. Then similarly from tidal volume up to the ERV, this is called as expiratory capacity. This is called as expiratory capacity. And then if I ask you, tell me how much air you can take maximum inside of the lung and how much you can exhale out. So you can tell me, sir, this much I can take inside and this much I can take outside. So this is called as your vital capacity. This is your vital capacity. Now, if I ask you how much air can present inside of your lung maximum, so this much is present up to this much is present. So this is called as total lung capacity. This is called as total lung capacity. Right? Now one question. That is the favorite for examiner. The favorite for examiner, the capacity which is after normal expiration from ERV to RV. From ERV to RV, expiratory reserve volume to residual volume. This is called your functional residual capacity. Functional residual capacity, and this is the question beta. NEET PG 5th March. The same diagram was given from your books, and they have been asked this question. So this is spirometry beta. Remember, tidal volume is 500 ml. 500 ml only. Inspiratory reserve volume 25 to 3000 ml. Then expiratory reserve volume 1000 to 1100 ml, and residual volume is again 1100 to 1200 ml. Then the inspiratory capacity, that is 3500. Expiratory again same. Then functional residual capacity 2500 or 2500 ml beta. Functional FRC, that is your FRC. That is your FRC beta, right? And this is very important for exam purpose. Vital capacity, expiratory reserve volume plus tidal volume plus inspiratory reserve volume, or either I can say this is inspiratory capacity plus ERV. Similarly, this is also like this, or IC plus FRC. So this is all this 6000 ml air can come inside of your lung. Always remember beta, through the spirometry, only those air you can identify which are getting inside and can coming outside. But the air which is present inside already and which is not coming out at any point of view, this is called your residual volume. And the any capacity where the residual volume is already including in this capacity, they also can't measure with the help of this spirometry. So what are they? That is FRC. FRC is ERV plus RV. RV is itself, and TLC also can't measure by the spirometry. Can't measure by spirometry. Can't measure by spirometry. So for measuring of this, we use the helium dilution method. Helium dilution method. For dead space, we use the measure. This is single breath nitrogen test. Single breath nitrogen test, or Fowler's and Fowler's method. And Fowler's method. Right? Coming to the next, that is forced expiratory volume. What is the forced expiratory volume? Forced expiratory volume is nothing. If a patient comes to your OPD, you ask to this patient, please take a deep breath. Please take a deep breath, and then you just ask to this patient, please do the forceful expiration, forceful exhalation. And once this patient will do the forceful exhalation, but what happens? Ideally, around 70 to 78% air comes out in the 1 second. That is called your FEV1. In second, the air comes out around 94%, and FE3, the air comes out around 97%. So air comes in the first second, air comes in second, air comes in third second. This is called your forced expiratory volume, right? Now what happens? FEV1 normal value is around 78 to 880. This is 78% of FVC. Then 94% of FVC and 97% of FVC. 97% of FVC. Now always remember, if there is a problem into the exhalation beta, this is called as obstructive lung disease, and if there is a problem into inhalation, this is called as restrictive lung disease. अगर सांस छोड़ने में दिक्कत है, OLD, सांस लेने में दिक्कत है, RLD, right बेटा? Next is respiratory quotient. Respiratory quotient is nothing. How much CO2 is producing inside of your body and how much oxygen is getting inside of your body. The ratio of this is called as respiratory quotient. But remember, every time output is 200 ml per minute and oxygen uptake around 250 ml per minute. So normal value is 200 upon 250. This is around 0.8. So this is the normal value 0.8. Question comes: carbohydrate respiratory quotient is 1. Protein 0.83. Very less for the fat, that is 0.7. And for the brain, again, this is 1. MCQ beta. In exercise beta, do the correction, this is increases. In exercises, respiratory quotient is increased. VO2 again remain only 4000, but VCO2 is 8000. Capacity, total oxygen getting inside, that is 4000 ml, but carbon dioxide is producing inside, that is 8000 ml. Okay, beta. Coming to the next, that is normal respiratory rate. But similarly, how much percent will be smaller? The rate of respiration and rate of heart is very high. The person will become bigger and bigger in size. The rate of heart is decreases, rate of respiration is decreases. So in newborn, this is 30 to 60 per minute. In early childhood, this is 20 to 40 per minute. Late childhood, 15 to 30. And right now in your age group, this is 12 to 16 per minute. Right, beta? 12 to 16 per minute. Now, suppose this 500 ml is going inside, right? We have talked about this tidal volume. So 500 ml is going from this nose up to this alveoli. Beta, क्या ये पूरी की पूरी हवा इस alveoli तक पहुंची? Whether this all the air reaches up to the alveoli? क्या सब कुछ पहुंचा है? No, ऐसा कभी नहीं होता है. अगर आप 500 ml हवा यहाँ से ले रहे हो और alveoli तक पहुंचा रहे हो, तो alveoli तक पहुंचती है सिर्फ 350, 350. 150 is gone. Where it's gone? It actually trapped into the conduction zone from this trachea to this terminal bronchiole. And this trapping of the air, this is called as dead space. What we call this? Dead space. So alveolar air volume 350 ml, anatomical dead space 150 ml, tidal volume 500 ml, or pulmonary volume. Minute ventilation is nothing. Respiratory rate multiplied by tidal volume. Tidal volume is 500. Respiratory normal is 12 to 16. So this is around 6000 ml. Alveolar ventilation again. This is 12 into 500 minus 150 is equal to 4200 ml. So 6000 is total capacity, but at the alveoli it is reaching only up to 4200 ml. Physiologically low vital capacity seen in beta, always remember this is in the females, child, old age, pregnant female, short stature and obese. This is the physiological low vital capacity. Why? Because less area providing to the lungs. Coming to the next, that is two type of respiration is present. That is internal respiration, number two external respiration. What happens, beta? What happens? Suppose this is your lungs, right? And this is your tissue. What happens, beta? This blood comes from here up to here, and from here up to here. Right, beta? Now what is happening? You are taking the oxygen. Now this oxygen, first of all, it should bind in the blood. then it should carry and it should enter into the tissue. Then only this oxygen will be utilized by the body. So number one, first of all, it is coming into the lungs, then it is going into the tissue level. So two type of respiration is seen. Number one, that is called as external respiration, and this is called as internal respiration. Right, beta? Now, what happens, beta? There is always this oxygen binds with the hemoglobin, and remember, with one hemoglobin there is 4 chains, alpha 1 2, beta 1 2. So is one hemoglobin, 4 ions of the oxygen can be bind, and if the atom they can ask, the oxygen is made up of the 2 atoms, so 8 atoms can be joined with this hemoglobin. Now, what is the function of hemoglobin? It basically transport all this oxygen from this area and then it delivers to the tissue level. But always remember, this hemoglobin is having a selfish nature. What happens? Whatever is more at which place, this hemoglobin just leaves out from that friend and it always gets a friendship that who is more on that area. Now tell me, beta, who is more in this area? When this hemoglobin is reaching over here, who is more in this area? Oxygen is more. So what will be happen? This carbon dioxide will be released and CO2 will be delivered back to the hemoglobin. So this is number one thing. At tissue level, what you can see, this oxygen is reaching over here. Now what is more over here? This is CO2 is more in this cell. So this CO2 will come out and it will bind with this hemoglobin called as carb amino hemoglobin, and then it goes back into the circulation. So this is how this is called your external respiration. This is called your internal respiration. Right, beta? Now this feature, what is the feature? When you give the CO2 out and makes a friendship with the oxygen at this level, this is called your Haldane effect. What we call this? Haldane effect. And at this level, what is happening, beta? The oxygen is delivering and CO2 is binding. Oxygen is delivering and CO2 is binding. This is called your which effect, beta? This is called your Bohr effect. Which effect? Bohr effect. So this internal respiration, this is at tissue level. Bohr effect seen in O2 transportation. Then external respiration, this is at alveolar level. This shows the Haldane effect regarding the CO2 transportation. Next is exchange of the gases. How the exchange of the gases occurs? Beta, there are total 3 factors. Number one, how much the solubility of the gas? Cut it down, beta. Cut it down. The solubility of the gas. CO2 is more soluble than the oxygen. Always remember. Number two, this is your alveoli. So this gas will come over here and then it will come into the blood. Beta. So what is happening? There is the thickness of the cell membrane is very much differs for diffusion of this gas easily. So this is diffusion membrane less than 1 mm thickness and area is 70 meter square. Then the partial pressure of the gas. Partial pressure of the gas means how much gas is present into this environment. Then only it can easily enter over here. Because the pressure is more, the gas can easily come inside of this vessel. So this is partial pressure of the gas. And partial pressure of gas is 21% of oxygen. CO2 is 0.03 mmHg. In atmosphere, 760 mmHg is the normal atmospheric pressure. In this, 159 mmHg is oxygen. That is 21%. 0.03 mmHg is CO2. That is 0.03%. What happens, beta? As you can see, this oxygen more in the air, so it comes inside. Once it will come inside, what is happening, beta? At the alveoli, due to the dead space, not all the oxygen is reaching up to this alveoli. So now only around 104 oxygen is reaching up to this alveoli. After this, what happens, beta? After this, what happens? From there, 1 second, beta, relax. This alveoli air is having 104 of mmHg of oxygen. So now what happens, beta? This oxygen will come from outside to inside. Then from this side, it will go into the artery. Why? Because in the artery there is only the 40 mmHg of oxygen is remaining. So now from 140 it is coming to the 40 mm size. Now next it is going into the transportation and going at a tissue level, delivering over here, and CO2 is binding. Once always remember, beta, not all the oxygen is delivered at this level. Not all the oxygen delivers at this level. Now what happens, beta? Only out of these 4 molecules, 1 molecule is delivered at this tissue level. It means it is only 25%. It is only 25%, and that is why yesterday, day before yesterday we talked about the myoglobin binds only 1 hemoglobin molecules in the muscles, right, beta? So then remaining of the oxygen goes back into the venous. Then this venous takes the oxygen, CO2, and CO2 is becoming around 45 mmHg. That is the normal condition, reaching over here, and then the CO2 goes out, and then from here again it goes into the environment. So this is how all this exchange of gases will be happening, beta. Question came last time in your 20th Jan exam. That's on the high altitude. Why there is a hypoxia? Why there is a hypoxia? And in the question they was giving there is a less hemoglobin due to the cold environment. You cannot expand your chest and something like this. The right answer of that question was due to the less partial pressure of the gas. You are having a hypoxia because due to the less pressure, this actually exchange from this area to this area cannot be differ. It cannot be happen. Right, beta? So here I have given all this table. In this table, this is not the alveoli, beta. This is due. This is artery. Make the correction. This is artery. Okay, this is your artery. Normally you have seen that we sometimes write something like this, something like this, something like this, something like this. This is the partial pressure of any gas in the air. If small a, partial pressure of the air, any gas in the artery. If capital A, partial pressure of any gas in the alveoli. And if V, partial pressure of any gas into the vein. So this is how you should understand. Normal P, that is air. Small a, that is an artery. Capital A, that is partial pressure in alveoli. And in V, that is partial pressure of vein of that particular gas. So in table I have mentioned different pressures. You can go through it. Now in the partial pressure, what is the partial pressure? This partial pressure is actually measured by the Dalton law, which we have studied in the schools. So this is the percentage of gas in total pressure. And remember, how much is the partial pressure? That much is the diffusion. That is why in the 100% oxygen, in 100% oxygen therapy, you are giving 100% oxygen. So this oxygen is going very well inside of the body. This is called as barometric therapy. Ideally, in the normal condition, you never take 100% oxygen. Right now, you are doing the respiration. So outside in environment, 78% is nitrogen, 21% is oxygen. So once you are doing the inspiration, this nitrogen is also going, oxygen is also going. Always remember. Now what happens, beta? That is why in the normal gas cylinder, oxygen cylinder, you have studied in the anesthesia, there is a nitrogen oxygen cylinder. Why? Because if you will get 100% oxygen, might be this 100% oxygen can lead to oxygen toxicity. Always remember. That is why you always take with a combination of nitrogen and oxygen. You are taking same gases in the cylinder, oxygen cylinder, like the environment. Remember, 1 gram of hemoglobin can bind with 1.3 ml of oxygen. 1.3 ml of oxygen. In 100 blood, there is around 15 gram of hemoglobin. So that is why 100 ml of blood. How much oxygen we can carry, beta? 15 gram of hemoglobin is there. 1 gram bind with 1.34. So it is around 20 ml. 1 hemoglobin bind with 4 molecules of oxygen. And at tissue level, total delivery of oxygen is around only 5 ml. Only one molecule of oxygen is delivered at the level of tissue. So this is only around 25%. Then how the transport of oxygen can be occurs, beta? How the transport of oxygen? This transport of oxygen occurs. So in artery that is 20 ml, in vein this is again the 15 ml. This binds with the hemoglobin and this is called oxyhemoglobin. And how much beta? This is 97%. 97% binds with the hemoglobin called as oxyhemoglobin and 3% is dissolved in the plasma. Then transport of the CO2 beta, maximum transport of CO2 is occurs in the form of bicarbonate, that is 70%. 23% in the binding with the hemoglobin, and when carbon dioxide binds with the hemoglobin, this is not a carboxyhemoglobin. This is carbaminohemoglobin. What is this? Carbaminohemoglobin. And remaining, that is 7%, it dissolved in the plasma. So whenever the hemoglobin binds with carbon monoxide, this is called carboxyhemoglobin. Always remember. If oxygen, oxyhemoglobin. If carbon dioxide, carbaminohemoglobin. And if it is with the iron, that is methylhemoglobin. But just remember these points. This question is never asked in your exam, but in PG they ask these questions. DLCO, diffusing capacity of lung of carbon monoxide. This is not CO2, this is carbon monoxide. And remember, when the diffusing capacity of carbon monoxide in the lung will be increased. This is in the good partial syndrome, in polycythemia vera, and in congestive heart failure. And it decreases in the interstitial lung disease, pulmonary fibrosis, emphysema, and lobectomy. Just remember these points. Okay? Might be the question can be asked from this area. Coming to the next, that is oxygen hemoglobin dissociation curve. Oxygen hemoglobin dissociation curve. If oxygen hemoglobin dissociation curve. But remember what happens at the level of its lungs, right? You are taking the oxygen inside, this oxygen going inside. Now this oxygen will bind with the hemoglobin, and then only it will travel into the blood, right? Now you know with the one hemoglobin, how many oxygen can be bind? 4 molecules of oxygen can be bind. What happens, beta? Whenever this one hemoglobin binds with the first molecule of the oxygen, whenever this hemoglobin binds with the first molecule of the oxygen, this first binding is having a very difficult. This first molecule binding is very difficult to bind. But once this one oxygen binds with the hemoglobin, it will immediately attract, or it will immediately ask to come to the rest of the 3 molecules, and those 3 molecules can easily bind with this hemoglobin. So this is how what happens due to the first molecule having very difficulty. So this graph takes very much time, and then immediately they binds very fastly those 3 molecules, and then what happens, beta? After some times it becomes saturated. So that is why, as you can see, this graph is coming into the S shape, or it is also called as sigmoid shape. So graph of this oxygen hemoglobin is S or sigmoid shape. S or sigmoid shape. But this is your right side, this is your left side. This is for partial pressure. This is the partial pressure of the oxygen, and this is the saturation of your oxygen. So at which partial pressure, how much oxygen can be saturated? So this is the on y-axis, that is saturation. On x-axis, that is your partial pressure of the oxygen. Right? Always remember this right side shifting of the curve. Question is asked when the oxygen hemoglobin dissociation curve will shift to the right. Understanding of this right curve, beta, always remember mnemonic is K-date. That is your K-date. Now what is K-date? C stands for CO2. C stands for CO2. A for acidosis, not alkalosis. D for 2,3-DPG. E for exercise, and T for temperature. T for temperature. So this is the mnemonic. Just always remember K-date. This K-date, right? So whenever the K-date, increase the K-date, the curve will always shift to the right side. Curve is always shift to the right side, right, beta? So this is the mnemonic K-date, right? Now what is the K-date? Look at in the graph. If there will be increased PSO2, HI, 2,3-DPG, exercises, and temperature, curve will always shift to the right. And whenever the curve will shift to the right, it means beta, affinity of the hemoglobin will be decreased and dissociation will be increased, right? So dissociation will be increased and affinity will be decreased, right? So affinity is decreased, dissociation is increased. But whatever this remain, that is always shift to this curve to the left. Means decrease PSO2, HIN, less temperature is less, fetus hemoglobin and myoglobin. This myoglobin, right, beta? This is always left shift, and affinity increases, dissociation is decreases. Dissociation is decreases. Remember, beta, in this myoglobin, suppose this is your myoglobin. So myoglobin can bind only 1 molecule of oxygen. So this is binding 1 molecule, going upside and saturated completely. So now you can see this graph. This graph is completely called as hyperbolic graph. So this is your hyperbolic graph. Hyperbolic graph. Hyperbolic graph. Right, beta? Hyperbolic graph. So what is P50 value? Question is asked, what is P50 value? But P50 value is nothing. P50 means the 50% of hemoglobin is saturated with how much partial pressure of the oxygen. Means जो 50% hemoglobin है, वो कितने partial pressure of oxygen के ऊपर saturate हो जाता है. So look at on this graph, look at on this graph. This is your 50% of hemoglobin saturated. Make a draw, make a line up to here, and then make the line. At which point it is coming? This is coming around 26 mmHg. So what is the normal P50 value? That is 26. It means at the 26 of partial pressure of the oxygen, this hemoglobin binds 50%. Right, beta? Now question comes. When the P50, what is the P50 value? When the in the left shift, P50 value will be decreased or increased, and in the right shift of the curve, P50 value will be increased or decreased. See, beta? If this is suppose your right side, so make the curve. Suppose this is the right side curve. Now what is the value, beta? What is the value? This is around 38. So P50 value will be increased. The curve will shift to the right. What about the left? This is your left. So this is around 18. So see, beta, if P50 value will be decreased, the curve will shift to the left. This is how the question can be framed. So if you know this graph very easily, beta, you can easily understand. This is the normal curve. So 50% oxygen saturated at 26 mmHg of partial pressure of the oxygen. If the P50 value will be increased, the curve will shift to the right. If P50 value is decreased, the curve will shift to the left. Right, beta? So write it down. P50 value is when hemoglobin binds 50% of oxygen. This is 26 mmHg. When P50 value will increases, it will shifting to the right. Decreases, it shifting to the left. Right, beta? Bohr effect, you already know. This is seen at tissue level. This is related to CO2 tissue level, is to decrease affinity of oxygen. Dissociation will be increased. Question comes, double Bohr effect is seen in, this is seen in placenta. This is seen in placenta. Double Bohr effect seen in placenta MCQ. Haldane effect, this seen at the alveolar level. This is related to increased oxygen binding with the hemoglobin that release the H ion related to CO2 transportation. Right, beta? And number third, that is the Hamburger phenomenon. This Hamburger phenomenon is nothing but this is also called as chloride shift. This is also called as chloride shift. What happens in Hamburger phenomenon, beta? You already know what happens. Yesterday also I told you what happens in the cell, beta. CO2 is produced plus water is produced. It makes H2CO3 with the help of carbonic anhydrase. This is called as carbonic acid. Now this carbonic acid will be dissociated into H ion and bicarbonate. Right? So this is how this H ion is forming and bicarbonate is forming. What happens, beta? This CO2 is producing into the cell, and from the cell, this CO2 coming out and entering into the blood. This is suppose your blood vessel. This is your blood vessels, right? So now what is happening, beta? This is your completely blood vessels. Now what happens? This blood vessels is actually, give me a minute, beta. This is again lagging, I think. Now I hope it is okay. So what happens, beta? This CO2 gets out from here, it enters into the plasma, and then it binds with the hemoglobin. Once it enters into the RBC, beta, in RBC there is a water. It makes with the help of carbonic anhydrase into H2CO3 and dissociated into HCO3 and H ion. Now we want this HCO3 production of the CO2 and this H ion. This HCO3 should be filtered out from the kidney, right, beta? And for filtering out, this should not remain inside the RBC. This should go into the plasma. And now, beta, when this bicarbonate goes out, this is a negative ion. So which is the most abundant extracellular anion, that is chlorine, which is the more negative ion present in outside area, that is chlorine. So if one negative ion is coming out, one negative ion will go inside of the cell, and this is called as chloride shift. And this phenomenon is called as Hamburger phenomena. This phenomenon is called as Hamburger phenomena. So this is how this CO2 transport occurs, beta, in your plasma vessels through this CO2, through this cell, right? Till now we already discussed about this, beta, intraalveolar pressure. So in intraalveolar pressure, we already discussed this is normal 760, or hypothetically we can count it as a 0 mmHg. During inspiration, what is happening, beta? This is changing into 1 mmHg. It is -1, so becoming 759. So this is always negative. During inspiration, it is always negative. So that is why from outside air going inside, and this is due to the extension of thorax and lungs. Air enters inside the alveolus. Intraalveolar pressure become again 0. Inspiration stops and again 760. During expiration, what is happening, beta? There is changes into +1 because you are doing the recoiling. Recoiling increases the pressure again +1 mmHg, so it will become the 761 mmHg. And this is always during its expiration. This is always into the positive, and this is due to the lung recoiling. This is due to lung recoiling. Air goes out from the alveolus. Air goes out from the alveolus. Intraalveolar pressure becomes 0. Expiration stops, and again it is 760. Again it is 760. Right, beta? Let's finish this pleural cavity also, beta. Then we'll take a break because we have started at 3 o'clock. So within 10 minutes we'll finish this pleural cavity as well, and then we'll take the break. And then we'll continue with the rest part of the respirations. Right, beta? Now, what is the pleural cavity? Pleural cavity, you all know that this is the lung. This is your lungs. And outside of this lungs area, there is a cavity called as pleural cavity. This is a closed cavity, beta. In this pleural cavity, the outer layer is called as your parietal layer. Outer layer is parietal layer, and inner layer is visceral pleura. So what happens, beta? This pleural cavity is actually, this is your lungs, for suppose. After this is a complete pleural cavity, and then there is a thoracic wall, chest wall. In between this area is a closed chamber, and its pressure is always negative. And it helps to actually expand this lungs out. This do not allow to collapse this lung. What will be happen, beta? Due to this negative pressure, this lungs never collapse inside, and it always remain inflated. What will be happen if due to any certain condition, if this pressure will become the positive, this lung will be collapsed, and this is called as pneumothorax, tension pneumothorax, right, beta? Now what happens? Inside of this pleural cavity, there is always the presence of the fluid, and the fluid which is present over here we call as pleural fluid. When this pleural fluid is normal, the normal formation of the pleural fluid is there, and it is normally absorbing back. The normal pleural fluid is present over there, no pathology is there. What happens when this pleural fluid is increases? But this is called your pleural effusion. This is called your pleural effusion. And remember, beta, what happens? Whenever the blood is there, whenever the water is there, this water is always drains to the lower side of the lungs, and this area is called as costophrenic angle. Which area is called as costophrenic angle? Because this is the phrenic muscles, and this is the ribs over here. So this is making a costophrenic angle. And whenever there is a pleural effusion is there, but this area is blunt due to the water, and this CP angle when blunt, you will immediately say this is your pleural effusion. This is your pleural effusion, right, beta? So it is a closed cavity. Pressure can be negative and positive. Pleural cavity always have negative pressure at rest, called intrapleural pressure or intrathoracic pressure. At rest, it is -2 mmHg or -5 cm H2 beta. Whenever you are doing forceful expiration means lungs is recoiling more and more and more, and area is increasing. So what is happening, beta? This pressure will become into positive, +20 to +30. Right? Always remember, beta, if pressure is positive, this will push lung inward. If pressure is negative, this will push lung outward. Which I told you, negative pressure, lung will come outside. Daily pleural fluid production, that is 5 to 10 ml. If pleural fluid increases, called as pleural effusion, and on X-ray, you will see blunt CP angle. Blunt CP angle. If water plus air both are there, beta, then for water we use the word hydro, for air we use the word pneumo. This is called as hydropneumothorax. And this hydropneumothorax, how you will find this hydropneumothorax, beta? You will find this is like a straight line, like this. This is like a straight line. So on X-ray, you will find a straight line. And only if there is a pneumothorax, then you will lose a lung marking. Loss of lung marking. This is tension pneumothorax, beta. I hope so. In surgery, sir already teach you this condition, beta. Oh my God, this is again lacking. 1 second, beta. In hydropneumothorax, beta, this is something like a straight line appears in the X-ray. Always remember, this is something like a straight line. This area completely gone, white area, and this is showing a straight line. This is your hydropneumothorax. And in air pneumothorax, there is a loss of lung marking. And air pneumothorax, if the pneumothorax is there only, the loss of lung marking will be there. The tension pneumothorax, but in tension pneumothorax, already sir told you about each and everything. What happens? Only air can go inside due to the some flap formation over there. This air cannot comes out, and this will doing more and more compressed to this lungs. As you can see in this photo, this lung is collapsing, and it will immediately shifting of this mediastinum as well to the opposite side. And you can see that this complete area full of air, and why this air can come inside but cannot go outside. Now, what is the immediate treatment? You just put a white ball needle over here, and immediately you will just take this air out from this air, and this is called as your thoracostomy. What we call this thoracostomy. So in this is emergency condition, and you have to put the white ball needle in the MCQ space, fifth intercostal space in adult, and second intercostal space in children. So this is how, beta. This is your hydropneumothorax. As you can see, this is the flat line. So this is hydropneumothorax, right, beta? This is loss of lung marking. So this is pneumothorax. This is how you can easily. This is your blunt CP angle. So this is your pleural effusion. In the examiner will always give you, beta, two things: whether these vitals are stable of this patient and vitals are not stable. How you, and if it is asking about the management of this patient, how you can easily mark that question right. But if patient is vitally stable, patient is not having any problem, then we also not having any problem. So we should wait and watch. But if vital is not stable, immediately we need the treatment. This is how you can easily find out the better choice of the question answer, right, beta, in MCQs. So this is all about this lungs. I hope that you are getting little with this respiratory systems, but once you will do the revision, you will understand each and everything, because I have reviewed each and everything in a very short manner. This is very much enough for your exam purpose, right, beta? So now we'll take a break. After the break, we'll finish remaining part of the respirations. We'll take a break for 20 minutes. So we'll start the class again after the 20 minutes. So right now, break for 20 minutes. Starts at 5:10 p.m. Right, beta? Class will start at 5:10 p.m. Hello, my dear friends. Welcome back after the break, beta. So before the break, we were talking about the respiratory systems, and we have finished the last topic, that is your pleural cavity. In the pleural cavity, we have seen the different X-rays and different pathologies. So the next topic is compliance. But compliance means nothing. Compliance means the stretchability. Compliance means the stretchability. So stretchability means the lungs, it is like a balloon. So it is when you are inflating this balloon, this is expanding like this. So what is the compliance of this lung? So for this stretchability power, we use the word compliance. So compliance means nothing, it is just a stretchability. So what is the normal compliance of the lung? That is 200 ml per centimeter S2. So ideally in the lung, 200 ml is the total lung compliance. If you will talk about the lung plus thoracic compliance, ideally should be more, but no, beta, this is less. Always remember. So this is always 100 ml per centimeter S2. But what happens? Normally lungs have a good compliance. So lungs can be very normally. The lungs can be easily expand and easily it can be recoiled. So this is good compliance and good recoiling. But what could be happen if lungs compliance is decreased? Lungs compliance decrease means lungs cannot expand properly. So if lungs cannot expand properly, the volume of air inside of this lung will be also decreases. So less air inside the lung. And in which condition this can be happen, beta? If there is a certain disease like parenchymal disease of the lungs, fibrosis of the lungs, or scoliosis or any inflammations. And if, beta, there is a problem for inhalation, this is the problem of the inhalation, because your lung is not expanding. If your lungs is not expanding, you cannot take the air inside of the lung. So this is the problem of inhalation, and this problem is called as restrictive lung disease. What we call this? Restrictive lung disease. Similarly, if your lungs having good compliance, like it's chewing gum, you will take the chewing gum and you will just stretch this chewing gum. So chewing gum can easily stretchable, but it cannot come back like this. So what is happening? This chewing gum having good stretchability or good compliance, but the recoiling is poor. So whenever you are taking air inside, your lung can easily expand up, but they cannot recoil back. And once your lungs cannot recoil back, beta, this is the problem of the exhalation. You cannot do the exhalation. So if there is a problem in the exhalation, this is called as obstructive lung disease, right? So if compliance is less air inside the lung, parenchymal disease, scoliosis, fibrosis, restrictive lung disease for air filling, called as restrictive lung disease, and problem in inspiration. Problem in inspiration, right, beta? Vice versa, if compliance is good and recoiling is poor, this is physiologically seen in old age. So that is why in the old age there is more COPD, beta. So more air inside the lung, known as emphysema, and this is called as obstructive lung disease. So this is problem in exhalation. Problem in exhalation, right, beta? Now coming to the formula for getting of this volume and pressure, beta. So what is happening? Normally volume is 200 ml. This is your healthy lung. But if volume is more, air volume is more than 200, it means more air inside the lung. It means more air, it means obstructive lung disease. And if less air, then this is restrictive lung disease. So this is how you can easily understand, beta. If more volume, then obstructive lung disease, less volume, restrictive lung disease. Next is flow volume curve. Beta, cut this curve like this because this is a PG level. What is the flow volume curve? In flow volume curve, nothing is there, beta. What happens? We'll draw a line like this and like this. What happens? In this line, this is your expiration and this is your inspiration. All right. Now, ideally, how much total lung capacity of your lung? This is your 6 liter. So 6 liter air can come inside the lung, and then you are doing the exhalation. And then there is some residual volume will be inside the lung. That the air which cannot come out, and this is around your 1.2 or 1.5 or 1.8 like this. So then after this time, you will do again the inspiration. So again you are doing the inspirations. So this is the normal lung flow volume curve. So normal flow is there, normal volume is there. What would be happen, beta? Suppose if this is the graph. In this graph, what is happening? In this graph, as you can see, this graph starts from the less air. Less air means that is a restrictive lung disease. So that lungs cannot expand properly. So less air coming inside. So then it is less air, and then it is expiration. Then again the inspiration and similar volume of the air. So if this condition is this, the question is asked: which graph is this? This shows which disease, and this shows, beta, your restrictive lung disease. This shows restrictive lung disease. Similarly, what is happening in the obstructive lung disease? That compliance is good, but recoiling is poor. So lung can expand at over limits. So see, total lung capacity increased, but when he is doing the expiration, after so much of effort, he can do the expiration, but after some time this expiration stops, and immediately after this starts the inspiration. So more amount of volume inside the lung. So this is your obstructive lung disease. Question is asked: which disease this is? This is your obstructive lung disease. So in your exam, how they ask, beta? They will give you the arrow and they will ask you which lung disease this is. So you should answer this is the restrictive lung disease just by seeing the less total lung capacity. It means this is restrictive lung disease. Total lung capacity is more. This is obstructive lung disease. Right, beta? So this is how you should easily understand this flow volume curve. So this is flow rate of air as well, exhale forcefully and maximally for total lung volume at the residual volume. Right, beta? Now next, Next is surface tension. Surface tension we already talked about. That is inward force which act maximum at air and fluid interaction. And because surface tension decrease the compliance. Because surface tension, surface tension will not allow to go the stretchability. So this surface tension always decrease the compliance. This is a vice versa of this compliance. So if alveoli is collapse, this condition is called as atelectasis. And if fluid is present inside the alveoli, this is called as pulmonary edema. So who will counter attack of the surface tension? This is reduced via surfactant. So what is the function of the surfactant? Surfactant actually decrease the surface tension, and most common surfactant is dipalmital lecithin DPPC. But in 5th March 2023 NEET PG exam, 2 question was there, and this 2 question was one of the most common surfactant, that is lecithin. Number 2, what is the true about the surfactant? Is decrease the surface tension and increase the compliance. This was the right answer. So just you have to understand this better. Okay, and this may clear over alveolar epithelium and prevent the collapse to alveoli and increases the compliance. Surfactant is increased by 2 hormones. Number 1, that is thyroid, and number 2 is sex hormones. Always remember. Coming to the next, that is your ventilation perfusion. What is the meaning of ventilation perfusion? But ventilation perfusion you have it many times. V2 ratio, right? V2 ratio. So what is ventilation? What is perfusion? Ventilation is nothing. Whenever you are taking the air inside from nose, your air is going up to the lungs. That is called as ventilation, right? And what is the perfusion? The blood is coming from the heart up to the lungs to take the oxygen. So blood is coming from the heart up to the lungs. This is called as perfusion. So air from nose to lungs, but ventilation, blood from heart up to the lungs. This is called your perfusion. So now you know that in 1 minute, how much air is getting inside? How much air getting inside? At alveolar level, what is the alveolar level? Ideally, every time 500 ml you are taking inside. Normal respiratory rate 12, but now for 12 into 5 that is 6000. But now 150 ml scraping inside this dead space. So only at the alveoli there is reaching only 350 ml. So 350 12 time it is around 40 to 100 ml. So what is the total ventilation? That is your 40 to 100 ml. Now what is the blood amount inside of your body? That is 5 liter. So 5 liter blood is coming continuously up to the lung into 1 minute. So that is perfusion is 5 liter. So now you know that V upon Q, V is 40 to 100, Q is 5000, and this is becoming the 0.8. So normal ratio is 0.8. Right, beta? Now question comes. What will be happen? What will be happen? Or when this VQ ratio is increased? When this VQ ratio is increased. Listen, beta. Suppose if V is 40 to 100 ml, V is 40 to 100 ml, but there is no perfusion. Why no perfusion? Might be pulmonary embolism. So perfusion is 0. What could be the answer? This is your infinity. So if there is any problem in the circulation, then VQ ratio becomes the infinity. But suppose if V is 0, V is 0 means no air coming inside the lung due to the some airway obstruction, foreign body obstruction, but blood is coming. So 0 upon 5000, this is your 0. So if V is 0 and Q is normal, then VQ ratio is 0. Right, beta? Always remember. So this is how you should easily understand about this VQ ratio. Right? Now, when this decreases, so this decreases when there is a decrease in ventilation. So VQ ratio less than 0.8. This increase the physiological dead space, example RLD or OLD. If VQ ratio is increased, it means decrease the perfusion more than 0.8 like pulmonary embolism. But you just tell me, whenever the air comes inside the lung, in which area this air will be more inside the lung? That is in the upper side or lower side? But always air always goes into the upper side. So more air into the upper side and less air into the lower side on the base. Now what about the blood? Blood is always present on the downside or upside? Blood is always present more into the downside due to the gravity. So now what is happening? More air, less blood. More blood, less air. It means in this area ventilation is more, upper side ventilation is more, and perfusion is less. It means V is more, Q is less. So this VQ will become the highest at the apex of the lung. In base of the lung, perfusion is more, but air is less. So V is less, Q is more. This is the lowest at the base of the lungs. XQ, maximum at apex of the lung and minimum at base of the lung. And due to this condition, beta, more amount of oxygen present into the upper area. And always you know that there is a normal tuberculosis bacteria present inside this environment. So whenever you are doing the breathing, this tuberculosis enters inside of your lung, this bacteria, TB bacteria, and it requires the oxygen. Where it will get the more oxygen? It will get the more oxygen into the apex of the lung. It will get more oxygen into apex of the lung. So that is why always in the TB, first you will find the page in apex of the lung. So in upper part of the lungs is always infected in first the TB. Then might be this complete lung can be affected. Next topic is beta hypoxia. For understanding the hypoxia, what is the hypoxia? Look at on this picture. You will easily understand all this hypoxia. Don't worry about it. Hypoxia is quite easy. There are 4 types of hypoxia. Number 1, hypoxia. Number 2, anemic hypoxia. Number 3, ischemic hypoxia. Number 4, histotoxic hypoxia. What are the features in which condition this hypoxia can be needed? Right, beta? Look at on this screen. Now, what is first of all you should understand what is the hypoxia? What is the hypoxia? Hypoxia is when oxygen is not reaching up to this cell. It means oxygen is not entering inside of this cell. If this cell is not getting the oxygen, this condition is called as hypoxia. Now, what are the possibilities that this cell is not getting the oxygen? Beta? This cell is not getting the oxygen. What are the possibilities? There are only 4 types of possibilities are there. Number 1 possibility. Suppose in this area there is no O2 in the atmosphere, there is no oxygen. If no oxygen in the atmosphere, क्या कोई ऑक्सीजन यहाँ से जाके अंदर यहाँ पहुंच पाएगी? क्या यहाँ पे कुछ ऑक्सीजन पहुंच पाएगी बेटा? यहाँ कोई भी ऑक्सीजन नहीं पहुंच पाएगी. It means no oxygen in the atmosphere, or ideally, or either if there is a damage in this lungs, if this lungs is damaged, then no oxygen can be mixed into the blood. Again, no oxygen will reach up to this tissue level. So if no oxygen in outside of this area and there is a problem in the lungs, then no oxygen is entering inside or no oxygen reaching into this tissue level. So this is called as hypoxia. So this is number 1 possibility. This is your number 1 possibility. Number 2, suppose this area is okay. बाहर lungs के अंदर सब कुछ ठीक है, lungs भी पूरे okay हैं, lungs is also good. But now this oxygen binds with the hemoglobin. There is a motor car for the oxygen, that is hemoglobin. It binds with the hemoglobin, then only it can reach up to this tissue level. As you know, 97% it binds with the hemoglobin. Suppose this hemoglobin is already busy. This hemoglobin is busy with some other gas like carbon monoxide, which is having more affinity power, or either there is anemia. There is an anemia. No hemoglobin is there. So if no hemoglobin is there, can this oxygen will bind with anything? And if this oxygen is not binding with anything, this oxygen is not reaching up to this tissue, again causing the hypoxia. So this hypoxia is called as anemic hypoxia. So number 2 possibility is anemic hypoxia. Suppose number 3 possibility, this area is okay, this area is okay, and this hemoglobin is okay. Everything is okay. But suppose this area is got the traffic jam, or this area is already gone. Means there is some landslide. गाड़ी जा रही थी बेटा, रास्ता ही टूट गया, रास्ते में जाम लग गया. Right बेटा? Now what could be happen? So can this oxygen can easily go through this area and can reach up to the tissue? No. Again, this oxygen cannot go above this area properly, and this cannot reach up to this tissue level. So if it cannot reach up to this tissue level like this, again, what is happening, beta? Again, there is a hypoxia. But now this time, this hypoxia is due to which condition, beta? Due to this vessel condition. This vessel is not okay. And if vessel is not okay, means there is some atherosclerosis, beta. There is some atherosclerosis, and due to this atherosclerosis, this oxygen is not reaching up to this area, right? So this condition is called as ischemic hypoxia. Which condition? Ischemic hypoxia. So third condition is ischemic hypoxia. What is the fourth possibility? But the fourth possibility, this is okay, this is okay, this is okay. But suppose this membrane oxygen reached up to this level, but from up to this level, this oxygen should cross the barrier of the cell membrane, then only it can enter inside of the cell. But suppose due to some toxins, this cell membrane is damaged. This cell membrane is damaged. And for cell we use the word histo, and for tissue we use the word histo, and this is a toxicity called as histotoxic. And that is why if due to this problem of this membrane, any oxygen cannot enter inside of the cell, this is called as histotoxic hypoxia. So fourth possibility is histotoxic hypoxia. So that is why there are four types of hypoxia. Number one, that is hypoxic hypoxia, anemic hypoxia, ischemic hypoxia, histotoxic hypoxia. This ischemic hypoxia is also called as stagnant hypoxia. Right, beta? So write it down. Hypoxic hypoxia due to absence of oxygen at lungs level, anemic due to poor binding, ischemic due to poor circulation, histotoxic due to poor cell membrane permeability. In hypoxic hypoxia, partial pressure of oxygen will be less, in rest all there is normal. Hemoglobin in anemic, that is less, in rest all normal. Blood flow velocity in ischemic, less, rest all normal. Tissue utilization of oxygen decrease in histotoxic, in rest everywhere is normal. Oxygen therapy efficacy beta 100% for hypoxic hypoxia, 75% for anemic, 50% for ischemic, but nil for histotoxic. Nil for histotoxic. Why? Because बेटा टिश्यू के ऊपर मेम्ब्रेन ही खराब है, बाहर से चाहे कितनी भी ऑक्सीजन दे दो क्या ये अंदर पहुंच पाएगी? अंदर कुछ भी ऑक्सीजन नहीं पहुंचेगी. एग्जांपल इज नंबर 1 हाई एल्टीट्यूड लंग डिजीज, लॉकडाउन डिजीज, कोरोना, ARDS, ILD. This is anemic is CO poisoning, anemia, hypovolemia, sickle cell disease, and decrease the RBC. Next is ischemic, that is atherosclerosis, that is localized edema, heart failure, MI, and BP. In histotoxic, this is due to cyanide poisoning. Cyanide poisoning, MCQ. That is due to cyanide poisoning, MCQ. Right, beta? Cyanide poisoning. Coming to the next, that is ventilation. In ventilation, what is happening? In ventilation, there is a pulmonary ventilation or alveolar ventilation. Pulmonary ventilation means air going in and out lungs per minute, or alveolar ventilation at the alveoli level. What is happening, beta, when you are doing the hyperventilation? When you are doing the hyperventilation, more CO2 is getting out. CO2 is acidic in nature. So what is happening? More CO2 is going out. It means body will become alkaline. So this is CO2 is going out. CO2 is the culprit. That is why the body becomes alkaline. This is called as respiratory alkalosis. So CO2 wash out in hyperventilation. CO2 wash out. This will decrease the pH CO2 level. This will decrease the pH CO2 level. Do the changes, beta. This is called as respiratory alkalosis. pH will become more than 7.45. In hypoventilation, CO2 will be retained. So CO2 retention. This will increase the pH CO2 more than 45 mmHg. This will lead to respiratory acidosis. So if CO2 will be more, this will lead to the acidosis. Already you know that. Right, beta? So now coming to the next topic, that is the regulation of respiration. That is neural control. How the neural control can regulate these conditions. But there are two things. First of all, breathing. You can control this breathing voluntarily as well. But you can control this breathing beta only up to the 40 seconds. Maximum you can hold your breathing only 40 seconds. After 40 seconds, even somebody will tell you that please hold for more. You can't hold this your breath. Why? Because there is neural center is activated and this will start your breathing higher and higher. So this breathing is regulated by two things. Number one, that is nervous control. Number two, I have some chemicals. So first of all, talking about the nervous control. This nervous control, beta, remember, neural anatomy of your finish, beta. So you know that this is your brain, then your diencephalon, midbrain, then this is pons, and this is your medulla, and this is your spinal cord. So this is medulla, this is pons, midbrain, and this is your forebrain. Right, beta? Now what happens? There are total 5 neural centers are present inside of your brain. And remember, beta, all these neural centers are present either in medulla or in pons. So only in two places these neural centers are present. Number 1 medulla, number 2 in pons. In medulla, first of all, the first center is present like this. Then another is like this. And another is like this. Right, beta? Then one center is like this, present over here in pons. And another center is present over this area. Right? So total 5 centers. 3 in medulla, 1, 2, 3, and 2 in pons. That is 1 and 2. Now, first of all, this first center, medulla, this is called as your pre-Porzinger complex. This is your pre-Porzinger complex. Pre-Porzinger complex. This is called your DRG. DRG means dorsal root ganglia. This is your VRG, ventral root ganglia. This is called your apneustic center. Apneustic center. And this is called your pneumotaxic center. Pneumotaxic center. Right? So total there are 5 centers, 3 in medulla, 2 in pons. First, that is pre-Porzinger complex. This is your pre-Porzinger complex, and this is the pacemaker of the respiration. So the pacemaker of the respiration is pre-Porzinger complex. Pacemaker of the heart is SA node. What is the pacemaker? But what happens? You can do this breathing with voluntary as well. Means when you are conscious, you can do this breathing normally. But what happens when you are sleeping? Once you are sleeping, you are not conscious state. And if you are not in conscious state, now who is doing this respiration? This respiration actually is controlled by this pre-Porzinger complex. So that is why this pre-Porzinger complex is called as pacemaker of the respiration. What could be happen if this pre-Porzinger complex is damaged? If this is damaged, what happens with you, beta? When you are into fully conscious state, you can do the respiration by your own willing. But once if you will sleep, this pre-Porzinger complex is not functioning properly, and immediately you can wake up, or either if you will not wake up, you can die due to the respiratory distress. Right, beta? Now this starts this respiration, and nearby of this area, that is DRG. This DRG actually maintains this rhythm of inspiration for the inspiration. So maintain the rhythm for inspiration. So starting from this pre-Porzinger, but maintain this DRG. So now what is the function of DRG? If you want to do the forceful exhalation, this forceful exhalation is done by this DRG. Right, beta? Coming to the next in that Pons center, Pontine center, that is number 1 apnea state. But if you want to do the deep inspiration, if you want to increase the depth of the inspiration, then who can do this? This can do this pneumotaxic, this apneutic center, which is present into this Pons. So apneustic center basically increase the depth of inspiration. Prepositional complex, this is for pacemaker of the aspiration. DRG for making a control of rhythm of this inspiration. VRG for forceful expiration. Apneustic for increase the depth of inspiration. And what is the pneumotaxic center? But a pneumotaxic center is like a brake. If you are doing the inspiration, your lung is inflating. This lung cannot inflate more than the limit. Either they can be burst out like a balloon. If you will blowing out the balloon, what will happen after this balloon? This balloon can be ruptured. So similarly, if you can blow your lungs above the normal limit, these lungs can be ruptured. So this is controlled via this pneumotaxic center. And this pneumotaxic center is actually controls all these sensations via vagus nerve. So vagus nerve gives the sensation that lung is already fully expanded. Please stop the inspiration. So this is like a brake for apneustic, brake for DRG. Right, beta? So that is how sometimes, beta, you have seen that a person is collapsed, standing nearby you, and he suddenly collapsed. Once he collapsed, there was nearby this stool, and he hit on this back portion on this neck. Once he hit on this back portion of this neck, no bleeding was occurred, nothing is occurred. But what happens, beta? Due to the damage of this area, this respiratory area, beta, this person goes into the respiratory distress condition, and he suddenly died. So that is why this area, beta, is quite important. No, never hit on this area to anybody. This is quite important. Yes, so there are total 5 center. Device will be number 1 Preporzinger, number 2 DRG, number 3 VRG. 2 in Pons, number 1 apneustic, number 2 pneumotaxic. Right, beta? So this is respiratory control. Number 1 pneumotaxic center. It limits inspiration. Apneustic center, increase depth of inspiration. Preporzinger complex is pacemaker of respiration. DRG is for quiet breathing. Normal breathing you are doing with the help of DRG. And VRG for forceful exhalation. Right, beta? Except this, there is something called chemoreceptor. Beta, what is the chemoreceptor? Chemoreceptor is nothing. Now, except of this, all the centers, the brain is placed some of the cells into the brain and some of the cells outside of the brain. And actually, these cells regulate this respiration with detecting the oxygen level. And they are like a sensor. So they are detecting for this oxygen. We are using the word chemoreceptor. Similarly, tomorrow we'll study in the CVS, beta. There is some sensor for the blood pressure as well. For those we use the word baroreceptor. So these chemoreceptor or baroreceptor, they are present outside of the brain, so called as peripheral chemoreceptor or baroreceptor, which is present inside of the brain, called as central chemoreceptor or baroreceptor. Now, what happens, beta? For talking about this peripheral chemoreceptor, what happens? This is suppose your heart. This is your heart. This aorta gets out from here like this, right, beta? And then it is going upside and going downside like this. Now what happens? It is going upside, it divides into internal carotid artery and external carotid artery. So what happens, beta? Actually, at this level, there is 2 points are there. Number 1, one body is there and one body is over here. And they are called as carotid body, and this is your aortic body. Now in this body, there is a special cell called as glomus cell. This is your glomus cell. What happens, beta? Oxygen is going like this. Oxygen is going into this blood downwards and upwards. There can be possibility that oxygen amount can be less, and this less oxygen can go up to the tissue level and lead to the hypoxia. So what happens? This DRG, this actually aortic body and this carotid body, which is having a glomus cell, and they are having a receptor for the oxygen. So what happens, beta? They are actually having, so suppose they are having a receptor over here. Suppose they are having like this. So they are having a receptor over here. And this receptor is sensing for the oxygen. So suppose this oxygen is coming, this oxygen should bind with this receptor. Once, if this receptor don't bind with this oxygen, this receptor will immediately tell these things to your nucleus. And this nucleus will tell that please close the potassium channel. The potassium, which is freely going inside and outside, we already know that. So this potassium will stop to going freely inside and outside. And after this time, when you will close this channel, what will be happening? This will increase the positivity of this glomus cell. And once the positivity is increased, this excite and this will immediately send signal to the brain that there is no oxygen. Please increase the respiration. And then you will start doing the hyperventilation. So this is how this chemoreceptor actually functions. Okay, beta? So this chemoreceptor and chemically chemoreceptor, this is chemoreceptor in peripheral. They are more detectable for the hypoxia, means oxygen, than the CO2. And location is carotid and aortic body. Right, beta? Carotid and aortic body. Then the central chemoreceptor. Central chemoreceptor, beta, direct stimulation for central chemoreceptor is HIM and indirect is CO2. So in the question they ask the direct stimulation, always mention for central chemoreceptor that is HIM, indirect stimulation is CO2. So when in the brain, more amount of CO2 will be there. What brain will sense? Why there is more CO2? Means there is less oxygen. So this brain will send the signal and increase the respirations. And location of this central chemoreceptor is into the medulla. What could be happen, beta? If you will do the cut section between pons and medulla, suppose this is your center. What could be happen if you will do a cut section like this? So means this medulla is intact with the lungs, but this area is gone. So what could be happen? If this area is gone, section above the medulla and below between the medulla and pons, this will starting doing the deep inspiration because no break is there. Pneumotaxic gone, so deep inspiration. If above the pons, no effect. Below the medulla, no respiration. If you cut the vagus nerve, then again, but nobody is there to tell that your lungs is already hyperinflated. So deep inspiration. If you do the cut section between pons and also pons and medulla and also section of the vagus, this will lead to the apneus. There is something called beta Hering-Breuer reflex. Hering-Breuer reflex is nothing. This is a stretching of the lungs limits inspiration. Means when your lungs is stretching, this stretch will give a reflex, and now they are starting into the recoil. This is called as Hering-Breuer reflex. Glomus cell, we already talked about it. Detect oxygen in the peripheral chemoreceptor. Coming to the next topic, that is deep sea diving. Beta, have you done the scuba? Have you done the scuba anytime? In this deep sea diving, beta, we will study about this Caisson disease, decompression thickness. Okay, so this is the last topic, deep sea diving. What is the deep sea diving? Have you done the scuba, beta? Let me check, beta. So beta, what is deep sea diving? In deep sea diving, beta, scuba. Scuba is nothing. This S stands for, in the scuba, you just wear a cylinder and goes deep into the sea. So now what is happening, beta? What is scuba? Scuba is self-containing underwater breathing apparatus. So what is the scuba? Self-containing underwater breathing apparatus. So scuba is a short form. The long form is self-containing underwater breathing apparatus. So what happens, beta? When you are going deep into the sea, you are having your oxygen cylinder. In this oxygen cylinder, again, I already told you, there is both gases are there, like the atmosphere, nitrogen and oxygen. There is not only the oxygen, there is nitrogen and oxygen. Now what is happening, beta? When you are going deep into the sea, what happens, beta? This is your blood vessels. So this oxygen and nitrogen both are present inside of your blood vessels. Now what happens? This is the tissue. This is the tissue. So this oxygen will enter inside of this cell. So this oxygen is utilized, but nitrogen is not required to the cell. So this nitrogen will remain inside of this blood vessels. And now what happens, beta? This nitrogen is actually starts accumulating on the walls of this vessels, like this, on the walls of this vessels. So have you seen on the Coca-Cola bottle, beta? There is some bubbles on the wall of the bottles, right? What happens when your bottle is dropped down like this, or you will rotate bottle like this? Now what happens? If you will open immediately to this bottle like this, what will happen? All the Coca-Cola will come out, and all this bubbles will come out. And why this Coca-Cola is coming out, beta? Because what happens once you will rotate this condition like this, these bubbles actually they start accumulating on the surface area, on this walls. Now what is happening? Whenever you will open it, this bubble will try to come out very rapidly to the upside, and in between these bubbles there is a fluid. So basically this fluid will also come out due to this immediate coming out of this bubbles. What happens when you will do the slowly open this bottle? What happens, beta? This bubbles comes out very slowly, and no Coca-Cola comes out from this bottle. Similarly, what happens when you are going deep into this sea? So similarly, this nitrogen bubbles they start accumulating on this vessel wall. What happens, beta? If you are ascending up very rapidly, these bubbles also want to get out from your body very rapidly. So they all bubbles comes together and they are coming out from the lungs. And due to this certain condition, might be there can be a pulmonary air embolism, and this can block your blood supply to the lungs. And due to this condition, you can die. So who is the culprit? This nitrogen bubble is culprit, and this condition is called as decompression sickness. This is called as decompression sickness. So beta, next time whenever you are planning to go for the scuba, never ascend up very rapidly. Come very slowly, like this, like this, like this. Okay. Similarly, you have seen in the miners, they are also working into a very deep hole condition. What happens? These miners, when they are also coming outside very rapidly into the lift, what happens, beta? They are also having some kind of this problem. That is why in the Hollywood movie you have seen the miners when they are coming outside from this mine, so they are having a lift from up to this level, then they comes out, then again they takes another lift, then again at this level, then again comes out, and again goes like this. So they are comes out into the step position to not go into this sickness. And this disease, they are having a chest warmer over here, and this is called as Caisson's. So this disease is called as Caisson's disease. So this is the question comes: who is the culprit? Why this Caisson disease or decompression sickness is occurring? This is due to, beta, nitrogen bubbles. This is due to nitrogen bubbles. And every time, whenever in the 10 meter of down in the seawater, 1 atmospheric pressure changes, and in plain water it is 10.4 meter 1 atmospheric is changes. Right, beta? So coming to some applied physiology. In the applied physiology, beta, there is nothing like this. Everything I have mentioned over here. So suppose if surfactant is decreased in the children, this is called as, beta, respiratory distress syndrome or highly membrane disease. And if adult this condition is occurs, this is called as acute respiratory distress syndrome. Acute respiratory distress syndrome. And if surfactant is more, this will lead to more susceptible for bacteria and virus and infection. Right, beta? Some of the definition I have mentioned over here. So go through these definitions. All the definitions are there. And coming to the next, that is your plural pulmonary TB. In pulmonary TB, beta, I have told you the pulmonary TB page always first of all it will present into the apex of the lung. So as you can see, this is the total patch. This complete patch, can you see? This is the TB. So this is how you can easily understand that pulmonary TB is always into the upside. Right, beta? Always into the upside. Now, what is the emphysema? Emphysema is nothing when there is a decreased elasticity of the lungs. So lungs is inflated more rather than to recoil back. This is called the emphysema. This is a type of COPD, and most common cause is, beta, smoking. Most common cause is smoking. This is or exposure of oxygen gases, or also this is due to the alpha-1 antitrypsin deficiency, which inhibits actually the elastics. And this will increase the lung compliances and lead to pulmonary hypertension. So beta, this is all about this respiratory systems. Going through some exercises questions, beta, there is do remember points are there. So please don't forget to remember these points. Right? Surfactant to reduce the surface tension of the lung is produced by which pneumocyte? That is type 2 pneumocyte. Forceful expiration is done by which muscles? Forceful expiration. This is abdominal and internal intercostal muscle. Abdominal and internal intercostal muscle. FRC is measured by. How will measure the FRC, beta? Helium dilution method. Helium dilution method. And for dead space, we use the single breath nitrogen test or Fowler's method. Identify the alveolar volume, beta. Alveolar volume is 350 ml. And right shift of oxygen hemoglobin dissociation curve is done all except, beta, K-date. Remember K-date. Remember this K-date. K-date means hyperthermia, yes. Increase to 3 dPg, yes. Exercises, yes. Alkalosis, no. So this is the right answer. Alkalosis is the right answer. Normal P50 value is, already you know, what is the normal P50 value? This is oxygen hemoglobin dissociation curve. I already told you, this is the normal P50 value. This is the normal P50 value. This is around 26 mmHg to 25 mmHg. So I hope, beta, you have understood all these conditions. One more thing, please write it down. Anywhere you can write it down. There is something called, beta, Nernst equation. Number 1. Number 2, called as Goldman equation. Goldman equation. Number 3, called as Gibbs-Donan equation. Gibbs-Donan equation. Right? Nernst equation, Goldman equation, and Gibbs-Donan equation. What is the meaning of this equation? Beta, Nernst equation is nothing. Suppose if I ask you, beta, please tell me, this is the cell, and outside there is ion. This ion is getting inside and coming outside. So this is the equilibrium for a single ion. So if I'll ask you, beta, please identify that one ion, how much one ion can get inside of the cell and outside of the cell. So if a diffusing ion equilibrium, if I'll ask you this formula or this equation, you can calculate via the Nernst equation. So Nernst equation for the single diffusible ion equilibrium. If I ask you for the multiple ions, similar things, that how much multiple ions can be diffused inside of the cell and outside of the cell, this equation you can use via this Goldman. So Goldman for multiple diffusible ion equilibrium. This is your Goldman equation. Suppose if I will ask you, please tell me beta, for a non-diffusible, the ion which is not getting inside of the cell, for how this equilibrium we can get it. This is why this gives to an equilibrium. So this is for non-diffusible ion equilibrium. Yes, beta. Coming to the, please note it down, beta. We have missed one point on the page number 79. On page number 79, we have didn't write this point, beta. If tubular damage, then the cause less transport maximum glucose. This is known as your which condition, beta? Fanconi syndrome. This is your Fanconi syndrome. Fanconi syndrome. Yes, beta. So please, in the last, tell me, beta. This is the pH. pH is 7.65. CO2 and bicarbonate. CO2 is 21. Bicarbonate is 25. Which condition is this? Tell me, beta. Which condition is this? Please answer me. Which condition is this? Which condition is this? This is your, yes, beta. Everyone is right, beta. Yes, Sudarshan, Avinash. Yes, Sandeep, Harry, Simran, Shrenik. Yes, beta. Everybody you are right. Yes, Saurabh. Yes, beta. Very good, beta. Everybody is right, beta. Everybody is right. Respiratory alkalosis. Yes, beta. This is your respiratory alkalosis. Beta, one more thing. What is the most common surfactant? Tell me, beta, most common surfactant. Name of most common surfactant. Please answer me in the chat box. Most common surfactant is lecithin. Yes, beta, that is lecithin. Another name of this lecithin, This is your DPPC. Another name of lecithin, that is your DPPC. Yes, beta, very good, beta, very good. Everyone is right, beta. Yes, Satyans, yes, it is DPPC. Now tell me which pneumocyte produces this surfactant. Let's play 2-3 minutes this rapid fire, then we'll finish the class. Which pneumocyte produces this surfactant, beta? Type 2 pneumocyte. That is type 2 pneumocyte. Yes, beta. That is type 2 pneumocyte. Very good, beta, very good. Now tell me, beta, what is the alveolar ventilation? How much air is reaching up to the alveoli into the normal condition? Alveolar ventilation. Now answer me of this, beta. Alveolar ventilation. Yes, that is 350. That is 350 in one respiration and 4200 ml in 1 minute. Yes, beta, that is 350. How much is the dead space? Please answer me. How much is the dead space? Dead space volume? Yes, that is 150. Dead space volume is 150. Now tell me, beta. In this picture, we have understood that all the hypoxia in this picture, beta. Now tell me the hypoxia on the first number. Which hypoxia? On the first number. Name me this hypoxia, beta. Which hypoxia will occur if the problem on the first position? A problem in this condition. Which hypoxia, beta? That is our, yes, Harry. Yes, everyone. Yes, Nivya, Sandeep, Atul, Simran. Yes, beta. Pooja, Shrenik, Nitesh. Everyone you are right. That is hypoxia. Yes, beta. Yes. Everyone you are right. A problem is at second number. Beta. Now answer me. Yes, Pradyuman. Everyone is right, beta. A problem is in second number. Which type of hypoxia? In the second number? Now answer me for the second. Beta. That is your, yes, that is everyone. Absolutely, beta. That's a big clapping for all of you. Yes, this is anemic hypoxia. That is your anemic hypoxia. Yes, everyone you are right, beta. Everyone. Yes, very good, beta. Very good. If in this intention, beta, you will keep studying ना, आपको पास होने से कोई नहीं रोक सकता. अगर आप बस इस तरीके से पढ़ाई करते गए, आपको कोई भी नहीं रोक रहा है, आप इस FMG को फोड़ के निकल रहे हो. That is my guarantee, beta. Keep this momentum, beta, till the exam. Please keep studying in this way continuously, and you will pass this exam, beta. Okay, tell me, what is the hypoxia? If problem is at third place, what is hypoxia? Now answer me for the third number. Now. Yes, beta. Which hypoxia? If there is a third number, which hypoxia? Yes, beta. Yes, that is. Yes. That is traffic jam. Oh, Atul, it is traffic jam. So you can remember like this, traffic jam. Yes, beta. This is ischemic or stagnant. Yes, everyone you are right, beta. Everyone you are right, beta. This is ischemic. Very good, beta. Very good. This is your ischemic. Very good. Now if problem is at fourth number. Now answer me, beta, for the fourth number. Now. Problem is at the fourth number. Which type of hypoxia? Problem is at number 4. This is your, yes, histotoxic hypoxia. Yes, seen in cyanide poisoning. Yes, beta. Seen in cyanide poisoning, histotoxic due to membrane. Yes, Sandeep. Very good, beta. Very good. Well done. This is, yes, Atul, Pradyuman. Everyone you are right. Nitesh. Yes, Vaishnav. Yes, beta. Srishti. Everyone. This is histotoxic hypoxia. Histotoxic. Yes, Nitesh. I know that. Yes, this is histotoxic. Yes, beta. And now tell me, beta. Next is what is happening in the cones. Tell me now what will be happen if aldosterone is very more than the normal limit, or what is happening if aldosterone less than the normal limit. Which disease if aldosterone very much high? Which disease if aldosterone is very much high? Name of the disease. That is your cones. Yes, that is your cones. If aldosterone is high, that is your cones. Yes, beta, that is your cones. Now if aldosterone is very less, which disease? If aldosterone is less, which disease? Now answer me, beta. If aldosterone is less, that is your, yes, your Addison disease. Yes, beta, that is your Addison disease. Very good, beta. Very good. Everyone you are right, beta. Very good. Well done. Next is if ADH If ADH more than the normal condition, which disease? And if less than the normal condition, which disease? So if ADH is more than normal condition, then which disease? ADH above the normal limit. If ADH above the normal limit, which disease beta this is? Now answer me. If ADH is more than the normal limit, that is your, yes beta, yes, this is your CR. This is your SIADH. SIADH stands for syndrome of inappropriate antidiuretic hormone. Everyone, you are right. That is your CR. That is your CR. Okay, that is your CR. Now, if ADH is less than normal limit, which disease? If ADH is less than, which disease that is? This is which disease, beta? If ADH is less, beta, which disease? Let's see who will answer. If ADH is less than normal limit, yes, beta, this is diabetes insipidus. Diabetes insipidus. Yes, beta. So always remember, diabetes means polyuria. Diabetes means polyuria. Right, beta? Yes, everyone, you are right. Yes, beta. Everyone, you are right, beta. Everyone. Very good, beta. Everyone, you are right. Okay. So this is all for today, beta. This is all for today. Thank you very much, beta. Thank you very much. You have already my number. If you find any problem, beta, please write me on the WhatsApp. I will try my best to answer you as soon as possible. And tomorrow class will start in the second half. From 2 o'clock, we'll start the class, and tomorrow we'll finish the CVS and ECG, beta. Okay. So this is all for today, and we'll see you tomorrow afternoon. Okay, beta. Thank you very much. Keep study, keep revise on same day basis, beta. Thank you very much.